सर लाईव्ह झालो आहोत आपण, प्लीज सुरू करूया आपण.
ओके.
एक्सक्यूज मी.
येस सर, थँक यू.
आयडी बदलावं लागलं असं म्हणता तुम्ही.
A very good morning, good afternoon to all dignitaries online with us, our preeminent and magnificent speakers for the day, and all dear students. We all should endorse our appreciation for Maharashtra University of Health Sciences, Nashik, Maharashtra, for organizing such a unique and innovative academic activity on the digital platform. On and off the screen, it takes a lot of effort and integration of multitude of resources to bring it to you. So I hope all the students will attend carefully and harvest as much as academic excellence as possible. At the outset, let us thank all our speakers to accept invitation and being kind enough to deliver the lectures, and all the students will be learning from one of the best faculties in the country for the subjects to come. We have broadly divided the entire syllabus into 4 parts, and each speaker will speak for 50 minutes. So our first eminent speaker for the day is Dr. Manjusha Warhadpande, madam. She is professor and head of the Department of Conservative Dentistry and Endodontics, Dental College and Hospital, Nagpur. Ma'am, thank you so much for being here. Please start.
Thank you, Dr. Abrar. Am I audible? Am I audible?
Yes, ma'am, very clear. And you are online, ma'am, and everybody else will be on a mute now onwards.
Okay, okay.
I will contact you back.
Yes, yes.
Please go ahead. Thank you.
Thank you, Dr. Abrar. Good afternoon, all, and my co-speakers. Myself, Dr. Manjusha Warhadpande, Professor, Head of the Department of Conservative Dentistry and Endodontics, Government Dental College and Hospital, Nagpur. I would like to thank Team MUHS for inviting me as a speaker for rapid revision. I must appreciate this novel concept of rapid revision for all our dear exam-going students. In the present situation of pandemic of COVID-19, wherein everybody is under stress. So here is a small attempt to make our exam-going students a little stress-free by this rapid revision, which is conducted by Maharashtra University of Health Science, Nashik. Now, dear students, why revision? Someone has rightly said, the best stories are not only written, but they are rewritten. So let us make this re-revision of rapid revision of our subject, conservative dentistry and endodontics, be a memorable one and be as well useful to all the students. So let us begin with the today's rapid revision. Now, I will be covering these topics from our MUHS syllabus, which are properly framed. These are the basic topics, yet they are very, very important. I have the duty to include the conservative dentistry topics and few of the endodontics topics. In conservative dentistry, few basic topics, and in endodontics also few basic topics. Now, in the introduction of operative dentistry, okay, so this may be question put to you like, what is the definition of operative dentistry? To my view, even if the question is not asked, but it is expected from all of us, not only the students, to remember this definition, which contains everything of our subject. So, students, if a question is asked, define operative dentistry. So here the answer is, Operative dentistry is an art and science of the diagnosis, treatment, and prognosis of defects of teeth that do not require full coverage restorations for correction. Such treatment should result in the restoration of proper tooth form, function, and aesthetics while maintaining the physiologic integrity of the teeth in harmonious relationship with the adjacent hard and soft tissues, all of which should enhance the general health and welfare of the patient. Now, also instruments are written about the scope. Now, why we need to know in brief about the scope is that this is a wide variety of all the topics, because the materials which we are going to use, one must know, that is basic from the first year and second year, dental material science. Also, we are going to apply it to the tooth structure. Hence, we should know about the biologic basis and the enamel, dentin, and pulp and supporting structure, as well as the physiology, pathology of pulp. Then, most important thing is examination, diagnosis, and treatment planning, and the very important sterilization. The occlusion, because we are going to eat from this side, so occlusion has to be perfect, and to avoid the lot of TMJ problems and all that. The most important thing is which we have to study about it. When a patient comes to you, he comes for pain and he's very anxious. So you should also know about the control of pain and anxiety to make our patient very, very comfortable in the dental chair. Not only the restorative procedures, but also prevention. It is always said prevention is better than cure. So we all must, as a dental fraternity, should work in a team for the prevention of the dental diseases. Now, from this, that is the first introductory chapter, a small question, Viva question may also be asked to you is, who is a father of operative dentistry? Another are Dr. G.V. Black. So paying tributes to him, he's the father of operative dentistry. And if I ask you, who is father of modern dentistry, then the answer should be Perry Fouchard. Okay, so small Viva questions. If a senior examiner like me comes, so you may be put to such questions. Okay, I hope the first topic is covered by me. Now coming to the second topic, that is the instruments. Now the dentist cannot do anything without the instruments. When I was a student in final year, so one of very senior teacher of mine, he asked me to define instrument. And I couldn't answer anything. Then he answered my query and he said, ma'am, student, the instrument is the extension of human hand to perform the given task. So all our instruments are our extensions, but what is required is the judicious use of the instruments with the passion in our heart, so as to give a gentle touch to our patient, which will give us healing to our patients. So coming to the classification of instruments, as we all know, a question may be put, classify instruments. So the classification is given by Dr. G.V. Black and the Marzuk. So G.V. Black's classification, he has classified it into cutting instruments and non-cutting. In cutting, all those hand instruments, now probably we may need it in the pandemic, excavators, the chisels, and others. So in excavators, hatchet, a hoe excavator, and all that you all know about it. And also you should learn about the non-cutting instruments. The classification given by Marzuk, I feel it is actually, he has done it as per our procedural use. So he has classified the instruments into first set, that is exploring instruments. Why we need exploration of the instrument is for the diagnosis of a defect. Now for diagnosis, only instruments, only we have instruments, it's not correct. We need a dry field and we need a proper illumination. So when you have a proper drying and proper illumination, then you will be able to see what is hidden over there. So in this first class is exploring instruments, for drying, for illumination, retractors, probes, separators, all this. The second set is instruments which are required for the tooth structure removal. That is preparation of the tooth. May it be for any kind of restorative material. So it is again divided into A, B, and C. That is hand cutting instruments, rotary instruments, and the ultrasonic instruments. Then we have a third set, that is all restoring instruments. Now we are going to have this mixing instruments ready, the packing instruments, the condensing instruments, burnishing instruments, and the carving instruments. And the fourth is finishing and polishing of the instrument. So when a question is asked, you should be able to write a classification of the instruments given by Marzuk or Black, whatever is your teacher tells and whatever is the correct classification, you should know. The second question may be put to you is a very basic question again. It's a nomenclature of instruments. This is again given by our beloved G.V. Black, and it describes dental instrument as follows, which you all are very aware. First is order. Order is the purpose of the instrument. That is whether the instrument is used for excavation, whether it is used for burnishing or plugger, so on, whatever the function is. The suborder is it describes the position or manner of the use, where it will be a push or it will be a pull. In manner, it is used, the direction of the instrument. The third is the class. It describes the form of the blade. For example, whether it is a cutting, okay, so maybe a chisel or a hatchet, or if it is a burnishing instrument, it will be a burnishing like that. And the fourth is the subclass. That is, it denotes the angle or space of the shank. For example, whether it is a straight or whether there is no angle or whether there is any angle. Now, for the students, for Vibha, what we all do is we have a tray in front of the examiners and on the table, and the examiner, he picks up an instrument and asks the student to describe for hand instrument. Okay, so this way you have to describe. That is, first you have to describe whether it is a hand instrument, whether it is a rotary instrument, whatever it is, and then go on describing the parts of the instrument. So the instrument is divided into three parts: the handle, the shank, and the blade. If it is a cutting instrument, it will be blade. If it is a packing instrument, for example, you want to condense silver amalgam, so you need a round or a parallelogram condenser. So there it will not be a blade. It will be called as nib, N-I-B. So nib is for the non-cutting instruments and blade is for cutting instruments. Now, if an examiner like me might ask you, what is the working part of the nib with which you are able to condense the silver amalgam, then the answer would be the working part of the nib is called as face of the instrument, which is serrated for silver amalgam restorations, because then it prevents the slippage of the instrument from the restoring surface. Now, the next question may be put to you is the instrument formula. This instrument formula, again given by Dr. G.V. Black. There are two types of instrument formula: 3-unit formula and a 4-unit formula. The first unit, it denotes the width of the blade. The second unit indicates the length of the blade in millimeters. First in tenths of millimeters, second is in millimeters, and third unit, it represents the angle of the blade relative to the long axis of the handle of the instrument. Okay. Now, there are certain instruments, for example, gingival margin trimmer or an angle former, which has a cutting edge is other than the 90 degrees angle. So for those instruments, the fourth unit is placed. So gingival marginal tremor is a 4-unit formula. It has a 4-digit formula, 4-unit formula. So this 4-unit, it denotes the angle between the cutting edge and the long axis of the handle of the instrument. But when you write the formula, then this 4th unit is placed in the 2nd place. Now, for now, pardon me, because there's some problem. Yeah, then we come to the, I think you all know, you have understood about the rotary instruments. I have not gone into the all the details of the instruments. So just because this is a revision class, so a few points and the answer point of view, it's all been taken. Then the rotary instruments. So these rotary instruments, we all very aware about the handpieces, the burrs, and all other finishing and polishing instruments. So you are all well versed with the handpieces and the micromotor handpieces, that is quadrangle attachments, straight handpiece, and the aerotor handpiece. But a word of caution in this COVID-19 is that all the aerosol generating procedures by use of aerotor handpieces are all, I mean, as far as possible, you are not supposed to use it only for emergency patient, that too in a separate chamber with the rubber dam in place. So we all know about the rotary handpiece and burrs. Then the rotary cutting instruments for this we all know that they are all called as, initially they used to call as, they will be called, they used to be called as burrs. Okay, those were the burrs which had the material with which it is made up of, whether it is stainless steel, whether it is carbon steel, whether it is tungsten carbide. Okay, so the material with which it is made, those were classified. So they had the presence of blades, though they were termed as the burr. And then there are abrasives. All diamonds are the abrasives because their mechanism action is different. So they are called as abrasives. So there is a classification of burrs. Just in a quick way we'll go. That is according to the mode of the attachment. If you are using for an aerotor, it will be a friction type. You are using it for a micromotor, that is quadrangle handpiece conventional, it will be a latch type. According to its composition, it will be, as I already have told you, the tungsten carbide, the combination of both. Then again, it is depending upon the length of the shank, that is whether it is a long shank burr or it is a short shank burr, and all depending upon the shape of the burr, whether it is inverted cone, whether it is a tapered, cylindrical, whether it is a flat, whether it is spear, and all. So depending upon the shapes and depending upon this that we all know about it. And also you should be able to tell about the description of the instrument, which we have already covered. Now, my dear students, only knowing about the classification of instruments, the nomenclature of the instruments, and all other things, but it is not sufficient. Okay, what you are supposed to have in your hand is about the sharpness. If you are using a dull instrument, it's not going to perform the correct function. Okay, so as the MUHS is sharpening your memory by this revision, so also in your practice, in your posting, you also have to check for whether the instrument which you are using is a standardized one, whether it is a sharp one, and the most important thing is which most of the times, being the senior teacher in the field, I have seen that most of the students, they are neglecting the grasp and the guards. So you should know about the different grasp, different guards. This is guards, why it is important? Because by chance some burr, some instruments, some diamond disc, some of that which is speedily rotating in the oral cavity, it might slip from your hand and there will be a serious mishap. So theory is okay. But when it comes to practical, all those things which are given in the syllabus, one must know and one must implement it. Okay. Then also sterilization. Now, that way, every time we have to sterilization protocol we have to follow. But now in this during COVID session and post-COVID session or era, I can call it, I have labeled as an era. So there we have to be very, very careful about each and every instrument. May it be a critical instrument, may it be a semi-critical instrument, may it be your dental chair and all other things. So you have to follow the protocol of sterilization, which is given by as per the CDC guidelines of 2003, and most probably now there is amendment by 2018. So all routine sterilization methods are there, but with this the autoclave. And remember, before placing it to the autoclave, before placing it to the sterilization, you need to clean it. You need to have cleaning properly, and then in ultrasonic cleaner, and then subject it to sterilization to have its proper effect. The next topic is clinical examination and diagnosis. Why I have chosen this is also, again, it is very, very important in this today's scenario, because the patients will be now coming in a later period. So we have to have the thorough examination before that, the screening, the history recording, the record keeping, and the detailed case history, the detailed examination, and then charting of the cases, which you can reschedule, which cases are urgent, which cases are emergency, accordingly you have to do. So I feel this case history taking, clinical examination, and diagnosis is very, very important, because the correct diagnosis, it leads to the correct treatment, and you can be a successful dentist. So all these things, I need not go into the details because you all know. Only for the medical history, you have to be very, very careful. And as per the guidelines for COVID, you have to have, and please keep it safe with yourself. Then treatment planning, we all know it is again a theory question. So there are different phases of treatment plan: urgent phase, control phase, re-evaluation phase, definitive care phase, and the maintenance phase. So treatment planning, you have to do it. Then also these are few basic non-carious lesions of teeth, which you are supposed to know, because a patient comes to you, what is a hypoplasia? You have already studied in details in second year, but you must know what is a hypoplasia, what are different types, and what type of treatment you give. Then what is atresion, what is abrasion, also what is erosion, and the affractions also. So this is all the basic lesions which you are supposed to know, because from the theory point of view, even for Vibha, they can be asked, what is erosion? What is erosion? Okay, what is abrasion? What is atresion? What is affraction? Okay, because I am in Nagpur base, so we have many patients in our OPD. Our OPD is maybe of say 130 patients. So the 5% of it is they have the lesion of affractions, maybe because of the habit and all. So it's a clinical study is going on. So this you should know. And the most important thing I'll shift to it is the dental caries. Now for dental caries, because of dental caries, we are all there. We are going to go for the prevention and the treatment and the management and all things. So to define, a question may be asked, what is dental caries? So definition is, this is a long one given, but you should know by the Schaeffer, you should be knowing from the student that it is a microbial disease of the tooth structure in which there is dissolution and destruction of the organic and inorganic structures of the teeth. Now the etiology for this, we all know about, this is a karyogram or a tetrad, what we call it as. There are four. First is the host, that is the tooth. Then there is a substrate, which is fermentable carbohydrates, and there are bacteria which are there in the karyogenic biofilm. And the fourth is a time. Initially, long back, there were only three things: host, carbohydrates, that is, and the time was not there. Okay, now saliva is all set. This is a different way. So this etiology, again, a question may be asked, what is the etiology of dental caries? So you should be able to draw this diagram, okay? And also you should be able to explain what are the primary modifying factors and what are the secondary modifying factors. Because even if everything is there in patients, sometimes you find, sometimes you may not find. So all the attention should be given to all other factors. Also, are you aware of the caries balance theory? So on one side, what is safe for the tooth and what is bad for the teeth. Okay. So what is bad for the teeth is all if you are not maintaining your hygiene. Okay. You have insufficient of saliva, and so these may be the bad topics, and the dietary, that is the diet is not good. So this is a bad side. And safe side is what? You have the proper, that is salivary constituents are good. You're able to clean everything. There's no bacteria and all. So this is a balance theory. So if you're balancing, you're maintaining your hygiene, you're improving your diets, so there are less chances of formation of caries. So this is from the, again, answer point of view, this slide. Then the classification is based on the location. I'll just go fast. So depending upon the location of the tooth, it is classified as pit and fissure caries, smooth surface caries, then the tooth surface caries, then based upon the speed of caries progression, the acute or rampant caries. This you always, when you're posted in pedodontia, so you must be seeing all this thing. Chronic, it has got an onset, okay, acute and the chronic, and the arrested caries. Based on whether it is a new or recurrent caries lesion, initial or primary caries, recurrent or secondary caries. Based on the extent of caries, incipient caries, cavitated caries. Based on the pathways of caries spread with the tooth, forward caries and backward caries. You know, again a Viva question. What are backward caries? What are forward caries? So Viva question, you may say the direction, and if it is a SAQ, then you have to draw the diagram and explain the what is forward, what is backward. Then based on the number of tooth surface involved, like this is very simple, compound, complex, one surface, two surface, more than that. So this is again a classification based on the treatment and the restoration design. Again, class 1, class 2, class 3, class 4, and up to class 6. Based on whether caries is completely removed or not, residual caries. At times the time is up, okay, and we forget to. I mean, it's a by mistake. So some type of caries, it is left in the during preparation. So they are residual caries, and based on the age of the patient, nursing bottle caries, adolescent caries, and senile caries. Okay. So again, the question answer is I have given to you that you have to write like that. The diagnosis of the that is for caries. So there are traditional methods and there are recent methods. So traditional methods we are all versed with this. That is the proper flossing, fiber optical, tactile, and probe. The most important, mirror and probe, explorer. And the recent, you can just, I am just enlisted, zero radiography, digital radiographic methods, digital subtraction radiography, digital fiber optic transfibrillation, dyes for detection of caries, electric, all those, and diagnodent and all. So then prevention of dental caries, because we are a developing country and the caries are, it's a very on a high rate, the incidence. So we have to give, and we have to tell you have to tell your patients about how to maintain the oral hygiene and what is the role of diet, which I have already told you, and the application of pit and fissure sealants is very, very important as far as the prevention of dental caries. Then in the management of dental caries, there is preventive management, which evaluate the causative and modifying factors for caries, and it also encourages the remineralization of incipient caries. For operative management, what you do is we have to remove the infected dentin, and in such a way that provide protection for the pulp. Okay. So these are few things which you know about the management of the caries. Now let us all shift to the endodontics. Now for this, the endodontics, a definition may be asked to you. And the endodontics is that branch of dentistry that is concerned with the morphology, physiology, pathology of the human dental pulp and periradicular tissues. Its study and practice encompass the basic clinical science, including biology of the normal pulp, the etiology, diagnosis, prevention, and treatment of diseases and injuries of the pulp and associated periradicular conditions. The scope of endodontics will include differential diagnosis and treatment of pain or swelling of pulpal and periradicular origin, urgent and emergency treatment for the pain and swelling, and the pharmacologic use of restricted use of antibiotics wherever it is required, the analgesics, anti-inflammatory, and the urgent or the emergency management of traumatic injuries to the dentoalveolar structures. Also, the scope will include vital pulp treatment to include stepwise caries excavation, indirect and direct pulp capping, and pulpotomy procedures. Non-surgical root canal treatment for the permanent dentition. Also, it will include bleaching of discolored teeth, the treatment procedures such as post-endo course, which involving the root canal treated tooth is also one of the scope of our endodontics. Now, to go for a successful root canal treatment, what is required is to know and to be well versed with the morphology of root canal. Remember, our students, our subject teaching starts right from the first BDS, then second BDS, third BDS, and final BDS. There is no escape to it. So whatever you have learned in first BDS and second BDS, you have to just keep it in your brain or revise it, and this will be for lifelong. This will help you. So this is a very basic diagram which I have given you for the undergraduate students, which you know about it. No need to go and explain about it. So again, theory question may be asked, put to you. What is classification of root canals? So this is Vertukey's classification. It's very easy. Type 1 is one end, one open, one end. Type 2 is 2, 1. Type 3 is 1, 2, 1. Type 4 is 2, 2. Type 4 is 1, 2. Type 6 is 2, 1, 2. Type 7 is 1, 2, 1, 2. And additional types where we have 3, then 3 into 2, then 2 into 3, and 2, 3, 2. So this way, for an answer to this question, you have to write the name who has given the classification, and also you are supposed to draw a well-labeled diagram in the center of the page and give a proper labeling that what kind of classification it is. And I'm sure if you write like this, you will score good number of marks. Then there is another classification, which is Wien's classification. So here it is type 1 is 1 to 1, type 2 is 2 and 1, type 3 is 2, 2, and type 4 is 1, 2. So when a question is asked again, so the description or the answer should be in this way. Yeah, hello, can you, sir, Shishir sir, I have admitted you, so there was a, hello?
Yeah, madam, thank you, madam, thank you.
Yeah. So, sir, welcome, sir.
Thank you so much, madam.
This is Abrar, ma'am. Please continue, ma'am. Please.
Okay.
We all are keeping ourselves on mute for video and audio both. Thank you.
Yeah. Okay. Yeah.
Welcome, Shishir sir, please. Thank you.
Yeah. Okay. Hello.
Ma'am, you are audible. Please continue.
Yeah, actually, no, it had stopped. It had stopped.
Has stopped, ma'am.
It had stopped. Okay, just give me 1 second.
Easy.
Yeah.
Yes, continue, please.
Yeah. Now it is.
I'm going
Okay.
on.
Yeah. Thank you, Abrar. So
Yes.
just to continue with this thing, Shishir sir, for you is the Wien's classification. So if a question is asked like this, so I was telling the students
Okay.
to draw the diagram like this, and it should be a well-labeled diagram, and also it should be in the center of the page, and you put the name of the scientist who has given this, and accordingly, if you do like this, then there's a fair chance of getting a good marks. Okay, sir? Am I right? Yeah.
Absolutely.
So the next
Absolutely.
is, yes, sir. So the next is the we are going to start. We have finished with the morphology of the root canals. Now we are coming to switching over to the etiology of pulp diseases. Now we all know that when we are going to treat the pulp disease, one must know what are the etiological factors. So the Grossman has given the etiology is classified into the physical, the chemical, and the bacterial. In the physical, there is mechanical, thermal, and electrical. You know why? When I used to take this topic, I used to give one hint to the students. Remember MTE. Now it is MTA, so it is MTE. So M is mechanical, T is thermal, and E is electrical. In mechanical, there are again many things. That is, most important thing is trauma. The old edition of Engel has given etiology. There are 60 causes for the pulp disease. Okay, and we used to remember all those. But now we have made it simplified for you. But the most important thing in mechanical, you should know about the trauma. There may be trauma from vehicular accident, a home falling, a bite, a sports injury, and so on. Okay. Then second is the thermal, in which the heat produced because of the preparation of the cavities or from the restorative materials which you are going to use. So it might cause thermal damage to the pulp and lead to the pulpal disease. Electrical, we all know about the galvanism. When the galvanism is between the two dissimilar metals, so there will be a galvanism, and this electrical cause will be one of the causative factor for the pulpal disease. The chemicals, we all know, the oral cavity, all the teeth are subjected to the variety of beverages. Also, the persons who are working in the acid fumes factory. So this is because of that there can be a chemical and from the restorative materials. But now a question may be asked, which is the most important cause of the pulpal disease? So it is a bacterial cause, which you should be able to answer. Now, in a brief of the rationale of endodontic treatment, for this one should know what is the philosophy behind this. So in this, you know again the second BDS, the inflammation. You know about the inflammation, and there are only two things which you should remember. What does this inflammation do? The inflammation, first, what will do? It will restrict, okay, and second, it will allow for the repair. So this changes, this slide, it shows the irritants, then there are inflammatory changes, then there are protective mechanisms and all that, and it leads to a vicious cycle of inflammation, and then it ultimately leads to the disease here I have given as a irreversible pulpitis. So this rationale of endodontic treatment, for this theory question may be asked to you, and you should be able to write this in a detail. I have taken it in a short, but you have to write in a detail. And also the endodontic implications. We all know about fish. This fish experiment is that fish has described the foci of infection as 4 zones. Here you have to draw the diagram also, which is given in the Grossman. So the first zone is zone of infection, second zone of contamination, zone of irritation, and fourth is zone of stimulation. What are all contents of there that you have to study and write. Now the again question would be put to you is about the diseases of the pulp. Now there are many classifications, but this is clinical classification of the disease of the pulp. One of our senior examiner, when she used to come in Nagpur, sir, so she used to always ask, because every student, you know, they used to give this clinical classification of the disease. But then she used to ask, what is Baum's classification of pulpal diseases? So like that. But here I have put the clinical classification of the disease of the pulp. So here, the inflammatory diseases of the dental pulp. In this, reversible pulpitis and irreversible pulpitis. We all know, I need not go into the detail. Reversible goes back to the normalcy. Irreversible doesn't go back to the normalcy, and there are changes. So in irreversible pulpitis, symptomatic irreversible pulpitis, asymptomatic irreversible pulpitis, chronic hyperplastic pulpitis, that is called as pulp polyp, and internal resorption. The second is the pulp degenerations. Pardon me for a spelling mistake. There has to be calcific degeneration, atrophic degeneration, and there's fibrous degeneration. And the third is pulp necrosis. So this way you have to go and write the clinical classification of the pulp diseases. Now just I think I have 5 minutes. So I'll be able to tell you about only for pulp disease, only 2 lesions. So because acute irreversible pulpitis. Now you are given a patient and you have to chart the case history of the patient and arrive at a diagnosis so as to plan a treatment. So for this, what should be the method of writing answer to this question, or when you're taking a case history? This will be helpful for you in both the fields. So acute irreversible pulpitis is, how do you differ? First should be the definition, then there should be the typical symptoms, because these symptoms will help you to differentiate from the other lesions, whether it is reversible, whether it is a pulpal lesion, whether it is a periradicular lesion, whether it is a reversible lesion, whether it is a irreversible lesion, whether it is a acute lesion, whether it is a chronic lesion. So symptoms, when you extracting the information from the patient, so this symptoms is it's a very important, and here where you have to apply all your theory knowledge. What is symptom? If a Viva question is asked to you, symptom is the unit of information sought by the patient at the time of history. So this symptoms with the patient of acute irreversible pulpitis, we all must have gone into it, that there is a tremendous pain. Okay, there's a postural changes and the pain lingers on. The most important thing is that it comes with the stimulus, it may not come with the stimulus. It has a habit of lingering on for a while. The patient is all awake in the night, and when he changes the posture and all, these things are that there is no way but just to rush to the dentist, maybe on a telephonic, or he has to rush to the clinic. And then the other things, the radiographic findings, you should know. So there's hardly any, you won't be able to see any periapical rarefaction for acute irreversible pulpitis. There might be some, as well as is normal. Sometimes there may be a little widening of the PDL space can be evident. The diagnosis, as we have already known about it, that how to do the diagnosis. So in this, on the inspection, you will see a deep cavity which is extending to the pulp, or decay. Maybe a filling is there and there's a residual caries, and it is because of that also. The pulp may already be exposed or may not be exposed. Okay. But then this is again what is most important is you distinguish it from the acute and chronic reversible pulpitis by this thing. And the histopathology is also to be added. The treatment is pulpectomy, and the prognosis is favorable. Favorable if the pulp is removed, properly, and the prognosis for the tooth is always good. Also, there is one, I would like to take an example of a question is put to you. What is chronic hyperplastic pulpitis? Okay, so for chronic hyperplastic pulpitis, so this which we have discussed is the acute lesions, and the chronic lesion is okay, so chronic is the chronic hyperplastic pulpitis. Chronic hyperplastic pulpitis. So for this, if you have come across this cases, so here 3 things you have to remember. Okay, so first is the age of the patient, that usually the patients are of a younger type, where you have a young resistant pulp. And second point is that there is always, most of the times, there is an open cavity. Okay, and the third type is the stimulus in the form of caries is a slow and long standing stimulus, so which causes the proliferation of the pulp tissue. So this is a chronic hyperplastic pulpitis. When you ask the patient to open the mouth, you will be seeing a proliferated pulp tissue which easily bleeds on the provocation by the probe, and then the diagnosis is evident only. Only thing, one point here I would like to share with you is that you have to differentiate it with the gingival hyperplasia. So how you will differentiate from gingival hyperplasia? For gingival hyperplasia and for chronic hyperplastic pulpitis, you have to go on checking the stock of the proliferation. For hyperplasia, if you start locating it with the help of explorer, so it will be somewhere right in the center and in the where the pulp was located. Whereas for gingival hyperplasia, it will be in the interdental area. If you compare the vascularity of both this, then the pulp polyp will be more vascular as compared to gingival hyperplasia. So there are many acute conditions, there are many chronic conditions, but this is just for example, if a question is asked to you, so you should be able to write an answer from this way. I have prepared my presentation. Then the next is the diseases of periradicular tissue. So in this, again, a classification may be asked to you. So there is clinical classification of the disease of periradicular tissues. So it is symptomatic periradicular disease, which is symptomatic apical periodontitis associated with vital teeth, and symptomatic apical periodontitis associated with non-vital teeth. Next is acute alveolar abscess, and third is, which is very confusing with this, is the acute exacerbation of the asymptomatic apical periodontitis. The second is asymptomatic periradicular disease, where the asymptomatic apical periodontitis, chronic alveolar abscess, radicular cyst, and condensing osteitis, external roots resorption, persistent apical periodontitis, and diseases of periradical tissues of non-endodontic origin. So here, just an example of if it is asked acute apical abscess or acute alveolar abscess, again in the same way which is given in the Grossman, you have to write about the definition, its symptoms, that is the clinical features, and your radiographic findings, then the diagnosis, then the differential diagnosis, and the histopathology, and the treatment, and the prognosis of the teeth. So for this is only thing here, for primary, that is acute apical abscess, you have to, how you will differentiate it from phoenix abscess. So phoenix abscess is the acute exacerbation of chronic lesion. So only differentiating factor, all the signs and symptoms will be of the acute abscess. But what will be the differentiation criteria is the radiograph. So on the radiograph, you will find a nice periapical radiolucent lesion, which will be the only differentiating criteria for this. So with this, I end my presentation, and I tried to cover as far as possible the syllabus which is given by the MUHS. I am extremely thankful to MUHS and who has given me the opportunity. I hope I have tried to satisfy my students, and I wish all my students a very best of luck, and I know that they will come out in a flying colors. Thank you so much.
Thank you very much, ma'am, for such a simplified and a wonderful presentation. It was very simple and easy to understand for all the students, and I hope that all the attending students will be benefited from this rapid revision. Our next speaker for the day now comes is Dr. Shishir Singh sir, a very eminent and famous academician and a clinician from Mumbai. Sir was ex-clinical teaching fellow in UCI Eastman Dental Institute, London. Currently, sir is Dean Professor and Head, Department of Conservative Dentistry and Endodontics, Terna Dental College, Navi Mumbai. Sir, I invite you and please start your presentation. Thank you so much.
Thank you, Abrar, Dr. Abrar, for that introduction. And can I have the screen sharing happening, please?
Manjusha ma'am. Manjusha ma'am.
Yeah.
You have to make sir host.
Okay.
Yeah, it's done.
तुम्ही meeting exit करून enter करा परत ते चालतं.
Okay.
Has it happened?
Yeah, it has happened. Thank you. Thank you,
Okay,
ma'am.
great. So am I audible to everybody?
Yes, sir.
Okay. Good
It's
afternoon,
very
students.
clear.
And first of all, welcome you all to the rapid review program organized by our university for all of you all. I know all of you will be extremely stressed out at this point of time. So we have come over here with the best, hottest topics for you all, made it simple so you're able to understand how to tackle your exams. Essentially, my lecture is going to be covering four topics, which are really very hot topics. And either you have something in theory or something in practical or something in vivas from these topics. You can have you can have SAQs, you can have LAQs and MCQs, right? And also you will have viva questions. So what I'll be doing is that once I start the lecture, I'll be explaining to you all exactly how the questions can come for you, so it becomes easier for you to prepare. So having said this, let's go further. So once again, a very big thank you to Maharashtra University of Health Sciences, Dr. Kalidas Chavan sir, and the rest of the team for inviting me to take this lecture for all of you all. So I'm from Terna Dental College. This is the college where I've been working. So let's first talk about principles of cavity preparation. This is the basis, the absolute basis or basics of conservative dentistry. The first question anybody will ask you or you have to know is principles of cavity preparation. This can come as a full question. This has come as a short note. This has can come as a viva question. And in between these, many points can come as MCQ, right? So let's look at the definition of cavity preparation. Now, cavity preparation or tooth preparation is defined as a mechanical alteration of a defective, injured, or diseased tooth to best receive a restorative material that will re-establish a healthy state for the tooth, including aesthetic corrections where indicated, along with normal form and function. Difficult to mug this. Yes, but if you are able to get the gist of this, and even if you put this definition in your own words, So it is a mechanical alteration or mechanically altering a defected or an injured or a diseased tooth. If you can alter it so as to receive a restoration or a restorative material that will put back the tooth to health. Now, when you put back the tooth to health, what should it be doing? Its job of the tooth is for biting, that is mastication, for looks, that is aesthetic. So it is for aesthetics, for form and function. So when you are studying, you study in such a way that you understand these meanings. Don't mug it up, right? So it will be easier for you. So it is preparation that is done with a machine on the tooth, right, to clear defected part, injured part, diseased part, and then to place a restorative material over there that will put that tooth back into health, the normal health, such that it can have proper form, that it can have proper aesthetics, and it can have proper function. Okay, have you understood this? Now we go on to the next. Now, what is the objectives of cavity preparation? The objectives would be you remove all the defects with the protection of the pulp. So the pulp protection has to be done and all the defects should be out. Then you have to extend the restoration in a conservative manner, not in a haphazard manner, right? Now, we say there is an extension for prevention, but you have to be more conservative in your approach. And under the force of mastication, the tooth or the restoration, when the patient starts biting, that tooth or restoration should not fracture, should not break, should not get displaced. So, and last, aesthetically and functional placement of the restorative material. So you should remember these 4 or 5 objectives that are there. Now, having understood these objectives, basically, let me again repeat for you. Removing all the defects. The defect can be a crack, it can be a discoloration, it can be dental caries. Then you protect the pulp. Then you try and, if required, extend the restoration in a conservative manner. So you get it you get a better form contour, and you can take care of the various steps which I'm going to talk about. Now, and then when you bite or the force of mastication comes on the tooth, the filling and the tooth, that is the restoration and the tooth, both should not fracture and should not be displaced. Also allow for good aesthetic and functional placement of the restorative material. Now, once you define a cavity preparation, the next step, any examiner will ask you, please define steps of cavity preparation. And GV back steps of cavity preparation are the basic that we all should know, right? So they will ask you, please give me the steps of cavity preparation. You should immediately say the steps are outline form, resistance form, retention form, convenience form, toilet of the cavity, finishing of the enamel walls and margins. The moment you give this smart answer, the next thing they will ask you is define any of these things and talk about it in detail, right? So you must understand and you must learn these properly right in the beginning. So the GV Black has given us these steps or the principles for cavity preparation, which is the outline form, resistance form, retention form, convenience form, toilet of the cavity, and finishing the enamel walls and margins. The final steps after that is done is to remove any remaining enamel pit or fissure, infected dentin, or old restorative material, do pulp protection, if required, any secondary resistance and retention form, finishing the external walls of the cavity, and final procedure is cleaning, inspecting, and finally sealing of the restoration. Okay? I'll repeat it once more. Outline form, resistance form, retention form, convenience form, toilet of the cavity, finishing of the enamel walls and margins. These are the initial points or the initial steps. The final steps are whatever remaining dental caries, different defects that are there, infected dentin that is there, or restorative material that is there, that has to be removed. Then you have to do pulp protection. Then, if required, if you feel a lot of the tooth structure is lost, you might have to do some secondary resistance form and retention form features. Finish the external walls of the tooth preparation, and final procedure is cleaning, inspecting, and sealing. Now, when you're going into these steps are the same whether you're going to do an amalgam, you're going to do a glass ionomer, you're going to do a composite, you're going to do a inlay preparation, you're going to do a laminate veneer preparation, you're going to do an onlay preparation. But depending on the material that you are working on, there can be a few differences here and there. So very often, if you start answering well, then if the examiner wants to drop a little bit of a mouth, sir, they will say, oh, what material are you using? So you have to say, sir, I'm talking about amalgam. For composite, it is slightly different. For glass enoma, it is slightly different, right? So this is the way you will be examined. This is called the deep learning process. So now, if you're having a full question, you define, write down the property, write down the different steps. Now we'll take each step. Now you can have a short note also on each of these steps, right? So the outline form means you decide the final position of the cavity preparation margins, except for finishing the enamel walls and margins. The initial or preparing depth, preparing the initial depth should be zero point 0.2 to 0.8 millimeters below the dentino enamel junction. Remember, all cavity preparations have to be below the DE junction at about 0.25 to 0.5 millimeters below in sound denti, never in enamel. Okay. Now, there are some situations like if you're doing a composite, maybe you can get away by doing an enamel preparation because there we're going to use some other steps, right? So you have to be aware of this. This is how also get into the habit of making some artistic diagrams. You know, very often if there is not enough time or if you're not very comfortable writing or it takes long for you to write, then the best thing for you to do is to be in touch with some amount of drawing so you can explain things better, right? So here you can see the outline form includes all the pits and fissures. It includes the mesial and the distal margins, okay? And this is a 5 cusp type, right? Now, all weakened enamel and friable enamel should be removed. That is, no unsupporting enamel should be left behind. All the falls should be included, whether it is decay, whether it is cracked, whether it is stains or any such problems. The margins should be placed in such a position that you can afford good finishing of the margins of restoration. That is very, very important. Now, extend the preparation margin until sound tooth structure is obtained and no unsupported or weakened enamel remains. Avoid terminating the margins on extreme eminences such as cusp heights or rich crest. If the extension from a primary groove includes 1/2 or more of the cusp incline, consideration should be given to capping the cusp, right? So these are points that you must mention. You know, here is a diagram that shows you exactly where the cusp tip and also if you can understand, you can go ahead and depict it with diagrams also. The preparation margin should include all the fissures that cannot be eliminated by enameloplasty. So all these fissures should be included. Now, here automatically one question comes, enameloplasty. What is enameloplasty? So instead of making a full cavity here in this fissure, suppose you take a round burr and run it over here, immediately this groove can become like a concavity and you eliminate that fissure, that deep fissure where caries can occur and you have a concavity. So food will not get stuck over there. You are in enamel and also the chances of decay happening will be reduced, right? So this is what is enameloplasty. The initial pulp depth should be about 0.2 millimeters into dentine, but if it's a gold foil restoration, it should be 0.5 millimeters, right? So here, whenever you reply, you never give one figure. You give a like you can give 0.2 to 0.5, 0.2 to 0.7. So always you don't confirm with one figure, always you give a range. That's very, very important. Now, when the occlusion enamel has worn thin, where total cavity is 1.5 millimeters, connecting them too close to the falls or cavity preparation. So you can if there are two, if you are doing a upper first molar, very often you do a different mesial cavity and you do a different distal cavity. You don't cross the oblique ridge. So in case if there is only 0.5 millimeters difference between both the cavities, you might as well, you're better off connecting both of them and extend the outline form to provide convenience form. So it should be not too tiny that your instruments don't go in. What is the point of having a cavity preparation if your plastic instrument and your condensers don't go in? So it should be of a size which is not too big. That is, you're not weakening the tooth by too much loss of tooth structure. At the same time, it should be such that your instruments can go in when you want to do your base application or when you want to condense your amalgam. Now, step 2 is the resistance form. Now, again, you can get a question. Please define resistance form and how do you achieve it? Okay, short note. So you have to then talk about definition. Primary resistance form is defined as that shape and placement of the preparation walls that best enables both the restoration and the tooth to withstand fracture without fracture the masticatory forces. So what did it say? The shape that you give to the cavity such that neither the filling, neither the tooth can fracture when you are masticating or when it is being subjected to masticatory force. Got it? So I'll repeat again, primary resistance form is defined as that shape and placement of the preparation wall that best enables both the restoration and the tooth to withstand without fracture masticatory forces. Right? Now, how do you do this? There should be adequate thickness of restorative material. There should be a good box shape and there should be a flat floor. So you should know how much thickness of the restorative material. So for amalgam, how much you require. For composite, how much you require. For glass ionomer, how much you require. Then the shape of the cavity should be box shaped. It should be flat pulpal floor. It should not be a rough floor, right? These are very, very important things. So a flat floor, when you see over here, will prevent the restoration moving. There will be no movement of the restoration. But if you have a round pulpal floor, little bit of the restoration can rock. If the restoration rocks, then it will become loose. So it is always better to have very clean, straight, flat floors, no rounded pulpal floors. This may, especially if it is a non-bonded restoration like amalgam. Maybe if you're using composite or you're using glass ionomer where we are using bonding mechanism, then you can think about having a, you're okay with not having very, very flat line angles. Okay. So these points you must be able to understand, you must be able to bring out, you must be able to speak. The floor should be flat, okay, and relatively parallel to the cusp tips. Okay, see that it's parallel to the cusp tips relatively, because that is how this is not right. This is what you should have, right? Because here you won't know if the forces come, and if you are undermining this cusp can become weak. So it has to be relatively flat floor, relatively parallel to the cusp tips. Right? So these points all you must include when you're writing. Your cavo surface margin. Now the preparation should be such that if you are doing an amalgam, you have a 90 degrees butt joint. The cavo surface is a 90 degrees butt joint. If you are doing an inlay or a onlay, the cavo surface is a 25 or 20 to 30 degrees lap sliding joint. Okay, if you are doing composite, you have to have a finish line on a finishing margin on the enamel, right? So, and then you have to bevel it, right? So there are different types of bevel: slide bevel, long bevel, short bevel. Okay, so these different bevels are there. So depending on the different material that you're going to use or the restorative material that you're going to use, the design might differ a little bit. So basically, you should have no unsupported enamel, slightly rounded internal line angles. If you feel lot of tooth structure is removed and the cusps have become weak, think of capping those cusps. Preserve the cusp and marginal ridge as much as possible. And if required, if you're doing a composite or a glass ionomer, then you can look at the bonding of the restorative material. So that will also give you good resistance. That is when you have no unsupported enamel, you have slightly rounded internal line angles. If you have capped the weak cusp, if you have preserved the cusp and the marginal ridge, which are nice and strong, And if you are going to use a restorative material like composite, then the bonding of that composite material, the bonding technique that you use, these all contribute to the resistance form. This all contribute to factors that will prevent the filling or the restoration or the tooth from fracturing when it is subjected to masticatory forces. I hope you have got this fundamental clear. So we talked about the outline form, then we come to the resistance form, right? Now, once you finish the resistance form, then you come to the retention form. So resistance form, as I told you, was that form which will prevent the filling or the restoration or the tooth from fracturing when it is subjected to masticatory forces. Now let's look what happens to the retention form. The retention form, again, this part can come as a short note separately, or it can be a big question. Is that form of a conventional preparation that prevents or resists displacement or removal of the restoration from lifting or tipping forces. So retention form, most of the students in the Viva will say, it is that form that retains the restoration. No, it hasn't to be answered like that. It is the shape of form that is given to the conventional preparation that will prevent displacing or removing or prevent displacing or the restoration from coming out of the cavity due to tipping or lifting forces, right? This is retention form. Now, how do you achieve this? Now, before that, very often students get puzzled between resistance form and retention form. They are very separate entities, but very often the features which enhance retention form might also enhance resistance form. So actually they are two different things, but the factors, sometimes they can be used for both, right? So you don't get puzzled. Resistant form is the shape given to prevent the filling and the restoration and the tooth from fracturing during mastication, while retention form is the shape given so that the filling does not come out of the cavity due to tipping or lateral forces or occlusal forces. It's very, very simple, right? So how do you achieve the retention form? The retention form can be achieved by a box form, then convergence to the occlusal surface. That is, you have the floor diverging while the occlusal surface converging. You can make retention grooves, you can make pins, slots, dovetails. These first five, essentially, you will agree are mainly for composites. But if you're the first five are for amalgam. But if you're doing composites, then obviously you need acid etching for resin composite restoration, right? So here you can see in a class 2 tooth preparation, the external walls, you can see the base floor of the cavity is divergent while they're converging occlusally. So that this becomes an undercut, right? But when you are doing an inlay, right, you cannot have converging walls. You have to have almost or near parallel walls. So because the inlay is an extracoronal restoration, you put it in and you take it out. So if you have undercuts, you will not be able to take it out. And you have to have straight free flowing walls because you have to put the inlay in and you have to cement in it. So definitely for amalgam, you're required to have occlusal convergence, pulpal divergence, while for inlay, you need to have near parallel walls or maximum 2 to 5 degrees of slight amount of divergence. This is very, very important. You have to be very, very particular about this. Right? Now, having understood the main or the essential features or the primary features of resistance form, let's go on to the convenience form. The convenience form is that form of the cavity that will provide good observation, accessibility, and ease of operation in preparing and restoring the tooth. That is, you will give it such a shape, the design you make it in such a way, the shape is done in such a way that you can visualize it properly. You can access it. So your instruments can go in and come out. And because you can access it, there is ease of operation in preparing and restoring that tooth. Okay. So the examples of convenience form, right? On occasion, when you're obtaining this form, it may necessitate extension of the distal, mesial, facial, or lingual walls to gain adequate access to the deeper portion of the preparation. In class 2, extending the proximal preparation beyond the proximal contacts might be required. Now, in gold foil, establishing convenience points for the starting of foil condensation. These are all things that you might need to incorporate in your cavity design for you to be able to complete the restoration in a convenient form. Then your next step is removal of any remaining enamel, pit and fissure, infected dentine, and on restorative materials if indicated. So you must remove all the old restorative materials if there is anything. Now, all that will affect the aesthetic result of your new restoration. Old materials is compromising, needing detention. Like if old glass ionomer restoration, they have a weak bond to the tooth, and the new composite restoration using enamel and dentine bonding. Take an X-ray to see that the caries, if there is caries under the old material, all this should be removed. The tooth, whether there were any signs or symptoms beforehand. If it was asymptomatic, good. But that might also mean that maybe the tooth is non-vital. So in the X-ray, you have to see whether the decay was very deep near the pulp or it is hitting the pulp. So you have a filling. Below the filling, there's secondary caries. And that caries might have gone into the dental pulp. So all this you have to see by the X-ray, because otherwise you will start removing the filling, you will start doing all that thing, and you'll end up with a condition where you'll have a problem, right? So you have to be very, very clear about all of this. And then the periphery of the remaining old restorative material is not intact. Remove all those, the cavo surface, peripheries, all that thing should be clean. Then after you have done that, then you have to see, well, it's easy to say that an ideal cavity preparation has to be 0.5 millimeters below dentine, below the dentino enamel junction. But very often you don't get an ideal case. Very often the decay is very deep, but it has not hit the pulp. So it's never that your cavity is going to be 2.2 or 2.5 millimeter depth. It can be deeper still and can be very close to the pulp. So in that case, we have to protect the pulp. We have to protect the pulp from various injuries. Now, Manjusha madam just explained to you that the physical, chemical, thermal causes for pulpal injury, right? So physical is going very deep. And if you're using an air rotor without a coolant, if you don't use a coolant, you can cause heat changes. Chemicals. Now you have to be very careful what cement you're using, because the acid in the cement should not at any point of time irritate the underlying pulp. So I'll be talking a little bit more about pulp protection in my next topic after we finish this, right? Now, after you have done this basics, then you look at the cavity, and if you feel that you need to incorporate some more resistance and retention forms, that's called secondary resistance and retention form. So if it's a compound or a complex preparation, you might have to incorporate a retention lock. You might need to incorporate a groove. For retention, you need to make coves. So locks, grooves, and coves are secondary retention form. Here you can see you're using a tapered fissure burr to make a groove in the axiopulpal axiopulpal line angle, and at this line angle between the gingivo-buccal line angle, or you can do it at the gingivo-labial line angle. Okay. So automatically when you say about line angles, the next question the examiner might ask you, define a line angle. So you see a line angle is a place where two surfaces meet. Then they'll ask you what is a point angle. So you say the junction of three surfaces. Once you answer that, then we get more adventurous. Then we'll ask you how many line angles and point angles in a class 1. So we will say 8 line angles and 4 point angles. How many in a class 2? You will say 11 and 6. How many in a class 5? Will be again 4 and 8. How many in a class 3? It will be 6 and 3. And you're getting all your answers right. Then you will get a googly. The googly is how many line angles and point angles in a MOD cavity. And then you start counting. They are 14 and 8. Also, you should know how to name these line angles and point angles. Okay. So these very often when you answer your Viva questions, your answer will lead you to the next question, right? Over here, you can see how a groove is being done categorically. You can also use pins, amalgam pins. Okay, so you very often get a short note on amalgam pins. What are the different types of pins that can be used in amalgam? So you have to read about that. You have to talk about, I think there are friction lock pins, there are cemented pins, and they are the third one is retentive pins. So these three types of pins, their sizes, their commercial names, all that thing, cemented, friction lock, and the third one, it's slipping my mind. The third type of pin is there, which you need to talk about. Okay, so having talked about this, then these are how slots look and coves look. These are slots and coves. These are all secondary retention forms. Slot is a slot done over here. There's a cove done over here, and here you've got locks. Right. Now, then there are next step is finishing the external walls of the tooth preparation. That is to create the best marginal seal possible for between the restorative material and the tooth preparation. And you should be able to have a smooth marginal junction and provide maximum strength of both the tooth and the restorative material at and near the margin, right? So again, before I finish off this part of the topic, your principles of cavity preparations have to be understood from an amalgam restoration point of view, a composite restoration point of view, a glass ionomer restoration point of view, an inlay only, and a veneer restoration point of view. While for an amalgam, there is only mechanical retention. A composite can have chemomechanical retention. A glass ionomer can have chemical retention because they say glass ionomer is chemically bound to the tooth structure, right? The inlays, you're going to have basically cement, which is going to be the retentive factor. Onlay also same. Now we've got advanced retentive adhesion techniques where we have ways and means of trying to get some amount of chemical retention also. So these points you all need to be aware of when you're answering your question, your short notes, as well as your Viva questions and your MCQs. Correct? So having said this, now let's go on to the next topic that I have planned for you today is pulp protective agent. Now this comes again very, very important. It can come as a short note. It can come as a full question. It can come during your Vivas. And very often when you're doing your cavity preparation, when you're giving a practical exam, and suddenly you realize, oh my God, the cavity is very deep. Most of the time you're so nervous. So in the panic, you all try to go and make the cavity deep. Or sometimes really there is exposure because of dental caries. So at that time, you should not panic, because if you panic, then you will start going into a different vicious cycle, which you should not. Fine. If there is decay, if you're finding your cavity is going deep, stop, isolate the cavity, and you call the examiners or the experts and tell them that, sir, madam, the cavity is going deep. Please have a look. And what do you advise me? Some of them will say, okay, fine. What would you do? So either it's infected dentine or affected dentine. You take out the infected dentine, let the affected dentine be. So what is this procedure called? So you will say this is called pulp capping. What are the different types of pulp capping? This is how your questions will come. But before you go that deep, and suppose if you've done a decent cavity, still you have to protect your pulp with the help of a protective agent. Now let's see what are the different protective agents that are available. Now definitely this leads you to one big chapter in Anusavis, which is one of my all-time favorites, cavity liners, bases and varnishes. Okay, so it's very, very important for you to understand what is the difference between a varnish, a liner, a base. And then there is something called a sub base. So I'll just talk a little bit about this. Actually, these chapters can go on endlessly, but I'm trying to just give you the salient features, right? Cavity varnish. Open up the book of Anusavis. The definition is cavity varnish is defined as a natural gum, copal, or resin dissolved in an organic solvent such as chloroform, acetone, or ether. This is how a cavity varnish has to be defined. Beat it. Don't say anything more. So it is a varnish defined is defined as a natural gum, copal, or resin dissolving in organic solvents such as chloroform, acetone, or ether. What are the functions of a varnish? The varnish inhibits micro leakage under the restoration, prevents penetration of corrosion byproducts, that is amalgam blues, into underlying tooth structure, inhibits acid penetration into dentine tubules, seals the dentinal tubules temporarily, prevents post-operative sensitivity, and the cavity varnish acts as a barrier and prevents penetration of oral fluids into the underlying dentine from the tooth restoration interface. So first thing, it inhibits micro leakage. That is, chemicals cannot go from the, hello? I think somebody needs to mute their mic. There's some voice coming, please. So inhibit micro leakage. So chances of any fluid irritating the pulp is prevented because this forms a protective coating. Then you prevent corrosion byproducts, amalgam blues. There goes your next question. What is amalgam blues? Amalgam blues is discoloration of the dentine and the tooth happening because of corrosion byproducts from amalgam reaching or going into the dentinal tubules and onto the enamel rods. How does this happen? That is because when you are using amalgam alloy, which phase causes corrosion? Gamma 2 phase. The tin mercury phase reacts with the unreacted mercury and releases this. And these tin that is released goes and discolors all these byproducts, right? But if you are covering it or protecting it with a varnish, it will not penetrate the underlying dentinal tubule, right? So very often you can get side questions or corollary questions happening when you put in these answers. Acid penetration. So if you are using zinc phosphate, which is highly acidic, okay, or using zinc oxide eugenol, right? Now, definitely not zinc oxide eugenol, but if you're using zinc phosphate, the acid will penetrate deep. So it is better to apply the varnish and then apply the zinc phosphate so the acid doesn't go into the dentinal tubules and it can seal the tubules temporarily and automatically, because if you're protecting the tubules, the chances of post-operative sensitivity are less. The cavity varnish prevents oral fluids going into the underlying dentine from the tooth restoration interface. So it functions very, very well, but it prevents only chemical micro leakage. This is something you need to understand. Now the question comes that very often, what are the functions of zinc oxide eugenol and zinc phosphate when both are used as a base? Definitely, they are very strong, very effective. But zinc oxide eugenol also has got a beautiful obtundant effect or a palliative effect or a healing effect on the dental pulp. Now, for that healing effect to take place, it should be in contact with the dentine. So if you are going to apply varnish and then put zinc oxide eugenol, it's not going to work. The eugenol, zinc oxide eugenol will not be able to do its healing effect. So in some base materials, you put the base first and then the varnish. The Viva question here is, if you're using zinc phosphate, will you put the varnish first or the phosphate base first? Obviously, the varnish goes in first and then the phosphate, because the phosphoric acid will, being highly acidic, will penetrate the dentinal tubules and irritate the underlying dental pulp. Next question, what is the setting reaction of zinc phosphate? What is the pH of zinc phosphate, right? So when you're answering, you need to be doing this thing, understanding these points very well. Now, when we talk about corrosion, next thing is, can you define corrosion? What is tarnish? Obviously, tarnish is surface discoloration. What is corrosion? Corrosion is surface roughening, or there is chemically it gets spoiled. Now, what are the different types of corrosions? You have a wet corrosion, you have a dry corrosion. Then in that again, you have got concentration cell corrosion, the similar cell. So it is never ending. Actually, each of these topics can become a short note or even a full question. If you read Anosavis, Dental Materials, I mean, this is one book that I have been reading from my student time, Skinner Phillips, and read it step by step slowly. I'm sure you will be able to understand each thing. All these things are mentioned over there. Okay. So here you can see the varnish. This is a varnish that is available. Now you dry your cavity. This is your cavity here. And how do you apply the varnish? You use a applicator tip, or you use a sable hairbrush, or you use a sable hair brush, or a applicator tip. So here you can see you have a cavity which is dried and isolated. You've got a good outline form. You can see two small specks here where there is decay. So we had to go a little deep here. You've got lovely dovetails. Very beautiful. Now we are going to take this varnish with the help of an applicator tip. We are going to dip it and apply it on the floor of the cavity. A bit of it will go on the walls. After you apply, wait for about 2 minutes, it dries. After it dries, again apply another coat. One coat is not enough because very often some porosities remain. Now, if you see now, especially the girls, they apply nail polish. The varnish, that nail polish is something. One coat is not enough. Same way, it is the same way in which you apply this. So, having understood this, now let's look at what cavity liners. Cavity liners are one step higher than cavity varnishes. They function a little bit more better than cavity varnishes. Okay, so what they do, they are thin material, layers of materials that primarily provide a barrier to protect the dentine from residual reactants diffusing out of the restoration and or oral fluids that may penetrate leaky tooth restoration surfaces. I'll repeat, cavity liners are thin layers of materials used mainly to provide a barrier to protect the dentine from residual reactants diffusing out of the restoration or oral fluids that may penetrate leaky tooth restoration surfaces. So it is essentially an aqueous or volatile suspension or dispersion of zinc oxide, calcium hydroxide, or glass ionomer. So to make you understand very simply, it is something like a varnish in which there is either zinc oxide, there is calcium hydroxide, or glass ionomer particles dispersed. So when it is applied in a thin layer, in order to elicit a particular pulpal response, so when it is applied in a thin layer, what happens is the varnish with that medicament, that is either glass ionomer or zinc oxide or glass calcium hydroxide, coats your dentine, exposed dentine. The primary purpose being to serve as an intermediate bonding material between the tooth and the restoration. The preferred thickness for the liner is 0.5 millimeters. This is how you need to understand what a cavity liner is. Now, having understood a varnish here is a natural gum, copal, or resin dissolved in an organic solvent. It is a plain thing, gum, copal, or resin which is dissolved, and its job is only to prevent micro leakage. Okay. To that, when we add or suspend or disperse calcium hydroxide, zinc oxide, or glass ionomer as a medicament, it becomes a cavity liner. Again, there is only chemical protection. Okay. Bases, on the other hand, are used to provide physical, mechanical, chemical, thermal, and electrical protection to the dental pulp, because the varnishes and liners are very thin and they cannot provide heat protection, they cannot provide electrical protection and physical or mechanical protection. So the forces of mastication, or when you are condensing the restoration, the mechanical forces, it cannot prevent those. Okay, it cannot insulate the tooth against those. For that, you require a base. So again, I repeat, the bases are used to provide physical, chemical, thermal, mechanical, and electric protection to the dental pulp. The base supplements mechanical support for the restoration by distributing local stresses from the restoration to the underlying dentine surface. The ideal thickness of the cavity base is 1 to 2 millimeters. Now, here you have to be very sure you should have it the cavity is below the dentino-enamel junction, and then you put the base maybe about 1 to 1.5 to 2, and there should be enough place for the final restoration. So if you are having amalgam, you should have at least about 2 millimeter minimum of amalgam thickness to have good resistance form and good retention form. So you have to be very careful when you talk these. So now what are the functions of a base? The functions of a base are, it provides thermal protection to the pulp. So as Manjusha madam told you, PCB, physical, mechanical, chemical, PCB, physical, chemical, biological, or PCM, physical, chemical, mechanical, thermal, PCMTE, right? You can use any of these mnemonics, so it's easy for you to learn. So there's thermal protection of the pulp. It protects the pulp from mechanical trauma, protects the pulp from chemical irritation, acid penetration. It has a therapeutic effect on the pulp, and it protects the pulp from electrical stimulation caused by dissimilar metals or restorations, right? The different base materials that can be used are zinc phosphate, zinc oxide eugenol, reinforced zinc oxide eugenol, glass ionomers, polycarboxylates, and MTA. Now, you must know all these cements constituents. You should know each composition in detail. You should know the different types available, type 1, type 2, type 3, type 4, whatever. You should know the chemical setting and the way you mix these, mixing characteristics or handling, all these things. Now, all these cements again can come as short notes to you. Okay, so you have to understand. Then the other question will be, which of these cements can have chemical bonding? So we all know glass ionomer, polycarboxylates, right? MTA also to a certain is one that has got chemical bonding. Now the next question is, what is the type of chemical bonding? So you have the OOH, COOH molecules that will combine chemically with the hydroxy molecules, hydroxy apatite molecules. The COH is the hydroxy molecules which combine with the hydroxyapatite molecules present in the tooth structure. So you must know all these things. You must know the composition and constituents of all these cements because they are extremely, extremely important for you to understand this and be able to talk about them. Then if you go back, we said it should have a therapeutic effect on the pulp, right? So if you are going to use zinc oxide eugenol in a deep cavity, it is good because it's going to have a therapeutic effect. But if you're going to use zinc phosphate, well, it has got a very good compressive strength. It is very hard, but its acidity is so much that the pulp will get extremely irritated. The tooth might become extremely sensitive. So ideally, you need to first put a varnish and then a zinc phosphate base. Also, for zinc oxide eugenol, definitely first the zinc oxide eugenol base goes and then on top of that a varnish goes. You need to understand this thing carefully. Again, glass ionomer and polycarboxylates. Varnish first or glass ionomer first? Definitely glass ionomer first, because if you put varnish, then the glass ionomer or even the polycarboxylate cement cannot chemically bond to the tooth structure, tooth surface. Same thing with MTA. So you must use a little bit of your logic and then answer. And for that, you need to read these things. If you open up, I swear by Anu Savit, it's such a lovely book, and you can just read it over a period of time. You'll be able to imbibe all these little nuances that are there that are very, very important for you to understand. So you have got a liner. Now you've understood what is a varnish. You've understood what is a liner. You understood what is a base. Now suddenly there is something called a sub base. In the middle of all these things, some examiners like to put a little bit of a googly, as we call it, which is called a sub base. Sub base in teeth with deep cavities, which is very close to the pulp. Sometimes a layer of calcium hydroxide can be applied as a sub base. For example, you get dical. So in that, when you're removing the caries dentin, and only one area there is dental caries, so you take a round burr and remove that thing, and that area gets deep. So you could probably place in dical as a sub base, and then after that you can put your normal base, or you can put your liner or varnish or whatever, and go ahead and give the restoration. So this is the funda of the sub base, right? So now I have covered for you two topics from exam point of view. One is principles of cavity preparation with respect to various restorative materials. I have covered with you cavity pulp protection agent, that is cavity liners, bases, varnishes, and sub bases. Again, in relation to various restorative materials, as well as when they are being used in combination, what is the combination and the sequence of use. So these little things you need to clearly and properly understand. Then the next topic that we are going to touch today is soft tissue management and saliva control. Now, this again can come as a short note or it can come as a long question. Basically, it's important to be able to prevent your soft tissue from getting injured when you're working. At the same time, you should be able to control the saliva. Why do you need to do this? Why do you need to manage the tissues? The soft tissues you should manage so you can retract. What are the soft tissues? Your lip, your cheeks, and your tongue. So you should be able to manage them well so that when you're doing a cavity preparations, you don't injure any of them. Or even the gingiva. Gingiva also will come. You should not injure them or traumatize them, because if you injure or traumatize them, they'll get they'll start bleeding. They might get hurt, or there can be pain. There can be discomfort. There can be swelling. So you have to take care when you're retracting with your mirrors or your retractors. You have to do it gently. Now, saliva control. Now, very often, what happens? There is so much of saliva that comes. The saliva comes from where? The saliva comes from the submandibular salivary glands, from the sublingual salivary glands, and the parotid salivary glands, right? And the saliva can come and interfere with your vision. So if you're doing a cavity preparation, suddenly the patient starts salivating, you will not be able to see what you are doing. That's not all. So vision gets impaired, you're not able to work, and there are some materials where you need a dry operating field. And obviously, I would say for all the restorative materials, you require good isolation and a dry operating field so that there is no salivary and moisture contamination when these materials are setting chemically. So it's very, very important that you should be able to manage your soft tissues as well as control the saliva and the moisture that comes in your oral cavity when you're doing your restorations. Clear? Right. So if you understand this concept, then we'll go a little bit into how do you manage the soft tissue, how do you manage the saliva, how do you prevent moisture from coming into your operating field so that you can see properly, you can work easily, and the materials that you're using achieve the best properties, physical and chemical, without having saliva or moisture interfering when it is setting. Correct? So now let's have a little look. So basically, your isolation of the working area means you have to control the moisture and you have to manage the soft tissues, right? The moisture can be of 2 or 3 ways. The moisture can be one, so your saliva is there. Second thing, if you're using a aerator, the coolant, the water spray, that itself is going to cause a lot of problems. And that water that comes from your aerator, that has to be cleared and sorted out. You have to see that your operating field is dry. So how do you do this isolation? What are the techniques? So when you're controlling moisture, you're controlling saliva, you're controlling blood, and you're controlling the gingival clavicular fluid. These 3 points or these 3 aspects need to be controlled properly. You need to see that saliva secretion is bare minimum and you are able to isolate the tooth in such a way that the saliva gets collected somewhere else or it gets sucked out somewhere. Same thing with blood. Suppose suddenly if there is inflammation in the gums, you're doing a class 2 and the decay is below the gingival margin, and you start doing the proximal box and you realize that you have niched the gingival, interdental papilla or the gingiva over there, it's going to start bleeding. Same way, if there is some amount of gingivitis, there is gingival clavicular fluid. So you have to control this. You have to tackle this, and then go ahead and complete your work that you are doing. The soft tissues that you have to manage. You have your lips, you have your cheeks, your tongue, and your gingiva. So these four things need to be clean, clear, thoroughly managed so that you can have a very nice, clean, dry operating field. A field where you can visualize properly. A field where your instruments can go in and come out without there being any salivary or moisture contamination. A field wherein when you put the restorative material, it can set properly chemically so that it achieves the maximum best physical properties. This can happen only if the field is dry, only if the field doesn't have any saliva, only if the field doesn't have any moisture. Yeah. Right. So now let's look at how do you control this moisture. Right. So here, if you're having a long question, you can just write down this. You have got direct methods, indirect methods, and you can use drugs. Okay. Now the direct methods are using a rubber dam, cotton rolls and cotton roll holder, gauze pieces, absorbent wafers for the cheeks, suction devices, gingival retraction cords. Indirect methods is giving local anesthesia, and the drugs you can use are anti-sialogogues, anti-anxiety drugs, and muscle relaxants, right? So you can talk about each of this in detail. So when you talk about the direct methods, means you use the rubber dam. So we all know this rubber dam, sorry, 1 minute. The rubber dam would come as a short note, or it can come, the whole thing can be part of a long question. So rubber dam was invented in 1864 by Dr. S.C. Barnum, a New York practicing dentist. Beat it. Next thing is, what does rubber dam do? It isolates the tooth from the other teeth in the oral cavity. It keeps the tongue out of the way. It keeps the lip out of the way. It keeps the cheeks and the gingiva out of the way. Right? What are the parts of a rubber dam? Right? Now, in this rubber dam itself is about a 2 hours or 3 hours lecture. So I'm just trying to put it in brief for you. The rubber dam consists of a rubber dam material, a rubber dam frame, rubber dam clamp, rubber dam punch, rubber dam clamp holder. Okay, so the rubber dam is, the material is a soft latex. Okay, which comes in different sizes of 5" by 5" or 6" by 6". It can be a soft, medium, or hard, or soft body, light body, medium body, or heavy body. So depending on which tooth you're working on, it can retract that way. It comes in different colors. It comes in a green color, in a blue color, in a dark color. Why? It comes in different colors because when the light comes, the light will reflect from it, and you can see that tooth properly. It stands out better. You have a dull side and you have a shiny side. Always the dull side should be out, so the light doesn't get reflected on from that rubber dam onto you. So this is how you have a rubber dam. Now in the rubber dam, then also you have a frame. You have the rubber dam frame. The rubber dam frame essentially are of two types. You have a metal frame, which is the Young's metal frame, or you have the rubber plastic frame, which is called the Nygaard Osby frame. And what is the difference between the metal one and the plastic one? The metal one, if you're putting it, and if you take an X-ray, it's going to come as a radio opaque picture. But if you're using a plastic one like the Nygaard Osby, if you take a photo X-ray with the frame in place, it will not show on the X-ray because it is radiolucent. The metallic frame is radio opaque. Then when you look at the clamps, you have special clamps for the front anteriors and for the posteriors. You have clamps for the incisors, separate clamps for the premolars, separate clamp for the molars. Then even for deep or teeth that are at various angles, or they have not unerupted teeth or maloccluded teeth, you get different shapes of clamp that will fit on. So you have to see which clamp fits properly to that tooth, selected accordingly. Then you have a rubber dam punch. You use a rubber dam punch to make holes. The holes are made or punched into the rubber dam where the tooth fits. So depending on the shape or the size of the tooth, you decide on which size of the punch you're going to take. Then you have got cotton rolls and cotton holders. Now, cotton rolls and cotton holders are again very, very important because they at once absorb whatever saliva is forming, whatever liquid or anything is getting absorbed. Same with gauze pieces. Again, absorbent wafers, these are put along the cheek. So they will take care of your any secretions from the cheek. Now, the gauze or the cotton rolls, if you're working on an upper tooth, you should put it in the buccal sulcus so it will block the parotid duct. If you're working on the lower teeth, that is on the submandibular or the lower teeth, you need to put it below in the sublingual area such that you block the submandibular or you collect whatever saliva comes from the submandibular ducts or the submental ducts. Then you use the light, heavy body and the slow or the heavy duty suction. And then also gingival retraction cords are used. They contain hemostatic agents, which when placed inside the gingival, they will cause gingival retraction and reduce any type of bleeding as well as crevicular fluid. Also, if you use local anesthesia, the vasoconstrictor in that helps reduce some amount of the salivation. Okay. And if you find the patient salivates a lot, you can use anti-sialogogues. That different tablets come, pharmacological tablets come, which can be used. Anti-anxiety drugs can be given or muscle relaxant can be given so the patient is comfortable and doesn't salivate a lot. Having understood this, the soft tissue that we manage, again, the retraction of the gingiva can be physicochemical, chemical, mechanical, electrochemical, or surgical. Physicochemical is the gingival is forced away but in a lateral and apical direction, and you can use a rubber dam, you can use retraction cord or wooden wedges. In chemical means you can use vasoconstrictors, astringent and stiptins. The vasoconstrictors decrease hemorrhage such as adrenaline and noradrenaline, but they increase the blood pressure and blood sugar, and they are contraindicated in patients with hypertension and diabetes. The different astringents can be biological fluid coagulants or tissue coagulants. These are the various available: alum, aluminium phosphate, zinc chloride, and silver nitrate, etc. The electrosurgery means that when you're using a electrocautery, which when is used, you can at once use you can use a cautery and cauterize whichever area is bleeding is happening. Surgical means is using sharp scalpels to reduce interfering gum tissue surgically, or when you're doing crown lettering procedure, it takes some time. It cannot be done immediately and there is a healing period. So this takes care of your third topic. I'm coming to the fourth topic, which is vital pulp therapy. Again, a very interesting topic, can come as a full question, a short note, or even as Viva question. So the main aim of vital pulp therapy is to preserve and maintain the pulp tissue in a healthy state, and its objective is to stimulate the formation of reparative dentin to retain the tooth as a functional unit. The different pulp therapies are indirect pulp capping, direct pulp capping, pulpotomy, and apexogenesis, which definitely become vital pulp therapy. The non-vital therapy can be apexification and pulpectomy, and now we have regeneration also, right? So what are the different things? Let's look at that. Now, here you can see we've got in reversible pulpitis, you can do vital pulp therapy like pulp capping or pulpotomy. But in irreversible pulpitis, if it's a closed apex, no vital pulp therapy, root canal. But in open apex, you might have to do apexogenesis or apexification, right? So let's look at indirect pulp capping. It is defined as a procedure wherein a small amount of caries dentin is deliberately retained in deep caries areas of cavity preparation to avoid exposure of the pulp. So you never expose the pulp in indirect pulp capping. And then you place a medicament so as to permit healing. So it arrests the caries process, it promotes dentinal sclerosis, it stimulates the formation of tertiary dentin, and it remineralizes the caries. You have to take proper history. There should be no history of pain, good clinical examination. There can be a large caries lesion. The vitality test should be done and the tooth should be vital. Radiographically see that the pulp has not gone, the decay has not gone into the pulp, and the periapical picture is clear and normal. If there is a lot of pain in the night, if there's discoloration or mobility in the tooth, or if there's a large radiographic lesion, this is contraindicated. The materials used for indirect pulp capping are calcium hydroxide, glass ionomer, dentin bonding agents, biodentin, endosequence root repair material, and calcium enriched mixture. These are the few materials that you can use. So you need to know the components of each one and the constituents of each one of them. The next is direct pulp capping. Direct pulp capping is defined as the protection of a pulp exposed mechanically during removal of caries. The thing is, there is a small pinpoint exposure. Instead of going in for a root canal or anything more, you try isolate the tooth totally and at once seal that exposure site with a specific medicament like calcium hydroxide or MTA, such that the tooth comes back to normalcy. So if there is a small mechanical exposure, the diameter of exposure is less than 1 millimeter, or the exposure should be bright red hemorrhage that can be easily controlled by a cotton pellet with minimal exposure. The contraindication is if there is severe toothache at night, if there's spontaneous pain, or there is tooth mobility or thickening of the periodontal ligament space, or radiographic, there is evidence of pulpal and periapical degeneration. Again, the materials used can be any of these: calcium hydroxide, dentin bonding agents, MTA, lasers, BMP, and biodentin. Then we come to pulpotomy. Now, pulpotomy is defined, this definition is very important, as the amputation of a damaged, inflamed, or removal of the damaged, inflamed vital pulp from the coronal chamber, followed by placement of a medicament over the radicular pulp stumps to stimulate repair, fixation, or mummification of the remaining vital radicular pulp. So pulpotomy is defined as amputation of the affected and infected coronal pulp and preservation of the radicular pulp vitality. How do you do this? Very simple. Main thing is you preserve the vitality of the pulp, remove the infected, inflamed pulp, maintain it in good physiological condition such that the radicular pulp is healthy. The different ways or techniques or classifications are: you do a devitalization pulpotomy, which can be formocresol, electrosurgical, or laser. You do a preservation pulpotomy, that is glutaraldehyde at ferric sulfate, a regeneration inductive or reparative one, that is with calcium hydroxide or bone morphogenic protein, or you do, depending on the size of exposure, a Sweck's pulpotomy or a cervical pulpotomy, and depending on the number of visits, a single visit or a multiple visit. If you open Grossman, you will get all these things in detail. These are the indications when there is a mechanically exposed vital. The thing is, you take out the coronal portion of the pulp, put in a medicament, and see that the rest of the vitality of the pulp is maintained. That is very important. The caries exposure in vital asymptomatic primary teeth. In the treatment of pulpally involved primary teeth with clinical manifestations of inflammation, and in the treatment of pulpally involved permanent teeth with open apices, and in the treatment of fractured permanent teeth with pulp exposure is greater. The contraindication is sudden spontaneous pain, abnormal sensitivity to hot and cold. There's tenderness to percussion, there is swelling, sinus, pus, mobility, uncontrolled hemorrhage. There is external resorption seen in the X-rays. If there is a large periapical radiolucency or internal root resorption of pulp calcification, pulpotomy is contraindicated. So I think I've done it well in time. A little bit about epexogenesis is a term defined to preserve vital pulp tissue in the apical part of a root canal in order to complete formation of the root apex. This terminology is vital pulp therapy and is defined as treatment of a vital pulp in an immature tooth to permit continued dentin formation and apical closure. And this is how you have a wide open apex. The tooth is vital. You can use different calcium hydroxide or MTA and try and stimulate closure of the apex with this vital remaining pulp tissue. So with this, I think I've concluded the 4 topics. Thank you very much. And I think I'm at 3 o'clock sharp. I'm sure Vibha madam will be waiting to take over. So thank you very much, sir. And I'll take on to the next. Thank you.
Thank you very much, sir.
Yeah.
Thank you so much for a very simplified presentation. And it was the entire part of that syllabus in a nutshell. And definitely the student will be benefiting a lot from the whole presentation. Thank you very much, sir, once again.
Thank you so much. So I need to do a sharing for madam. How will it happen? or it's being done?
So you need to make her she is having admin privileges. Madam, can you hear me?
Yes, Dr. Abrar, I can hear you.
Ma'am.
I can hear you.
Can you share your screen right now, ma'am?
Yes, I will.
Yeah, please. Yeah, it's come. It's come. Thank you so much, Shishir sir. And now I welcome our next speaker, Madam Vibha Hegde, very eminent personality in the field of conservative dentistry and endodontics. She is professor and head of the Department of Conservative Dentistry and Endodontics at YMT Dental College and Hospital, Mumbai. And she is president-elect of Indian Association of Conservative Dentistry and Endodontics. Madam has been in teaching for more than 20 years. So I hope that all the students will pay attention and will be benefited from a lecture. Please start your lecture. Thank you so much.
So thank you, Dr. Abrar, for the generous introduction. And first and foremost, I would like to thank the panel of MUHS, which is headed under Dr. Jayant Palaskar sir and his entire efficient team, and my seniors, Dr. Boyer sir, and all the MUHS team who have immensely contributed to the success of this revision program. And it is entirely designed with the benefit of the student in mind, especially the exam going students. And I hope that they will benefit maximum out of these sessions. And as all the eminent speakers who have been there on the panel, I'm sure have contributed immensely to benefit the students. And there are going to be 8 topics which I will be covering. And my few tips which I would like to give to the students before is, everybody wants to know what is important from the exam point of view. So I'm sure during every exam or internals you go to your teachers and you ask, ma'am, sir, what is important in this topic? What should we read? So these are often the questions the students are interested in. Therefore, these are few topics which could be those questions that you all want to know, perhaps. And the way you write it is again very important. So please try and understand the question that is being asked, whether it is being asked for an LAQ, SAQ. So you have to keep a certain flow chart, a small format in your mind, that if it is coming for a LAQ, I would require to write all these things in detail. If it is a short question, I have to include only so much part of it. And that is how you have to do a mind mapping of the questions which are asked. So you can write your papers very smartly. That is the most important thing which I would like to tell you. And the second point is, you have to attempt to draw diagrams wherever necessary. Many a times it will make sense to depict all your points in the form of the schematics, if you can explain, or in the form of the diagrams. That can also be a self-explanatory thing, and perhaps it can be more impressive to your examiners. So please try to draw diagrams wherever necessary. And if you draw a diagram, then you really need not elaborate on the writing part. So also keep this second point in mind. Third thing, the neatness and the way you write your legible handwriting with not too much of cancellations is definitely a good impression on all your examiners. So please try to do that. So before you write, just take a moment to keep all these points in mind before you begin. So now I begin with a few my topics, that is your cast metal restorations. Now why I have chosen this topic is, this is the topic in the final year which you have perhaps learned in your first year and maybe not giving too much of attention to it. But cast metal restoration is very important when you come to your final years, and you will find that most of the questions that are asked to you are on this topic. Therefore, I suggest you to pay a good attention to it. These are the indirect restorative materials, of which we have 2 of them, that is your cast metals and the tooth colored restorative materials. So you have the ceramic restorations, and you have the high gold, low gold, and palladium based alloys, etc. So you must know what the classification. So according to the Marzuk, we have the different type of the alloys. You have the class 1, class 2, class 3, and class 4, of which the class 1 are the gold and platinum. You have the low gold, non-gold, palladium based alloys, nickel chromium, and the cast ceramic metal alloys. So let us come to the cast restorations. What is inlay? by definition is defined as an indirect restoration involving the occlusal and the proximal surfaces of the posterior teeth and may cap one or more but not all of the cusp. The most important thing you have to remember here is that it does not cap all of the cusps. Classically asked in your Viva as to define. And please note down that when we are saying that this is an exam oriented revision lecture, it may be a Viva or it may be your simple chair side question. It can be a short note or it can be a LAQ. So it may be theoretical, it may be practical, or it can be your material Viva, which we generally ask on the table. So the indications: large restoration, endodontically treated teeth at the risk for fracture, for dental rehabilitation with the cast metal alloys, diastema closure and occlusal plane corrections, as a prosthodontic abutment, adjunct to the periodontal therapy, subgingival lesions, and low plaque index or the decay. The contraindications are again high plaque index, young patients, aesthetics, small restorations, occlusal disharmony, and dissimilar metals. Coming to the advantages, the main advantages of the cast restorations, it's always we look at substituting whenever there are, as we said in one of the indications, is that they are the large restorations, or we are using it whenever we experience there are a lot of fractured amalgam restoration. So the advantages would be the strength, the biocompatibility, the low wear, and control of contacts and contours, which is not possible to achieve with the other restorations. And the disadvantages, of course, it weakens the tooth. The dissimilar metals can lead to galvanism and chair side times. Cost and technique is important, and it can also cause abrasion of opposing tooth, especially if they are the ceramics. So principles of cavity design, there are three important concepts of the cast restorations. What are those concepts? One is the path of the insertion and withdrawal. You should have a single path of insertion and withdrawal. The taper, there's a second concept, that is the apical occlusal taper. There should be a slight divergence extracoronally, which permits unobstructed removal of the wax pattern and allows for the seating of the cast restoration. Therefore, a taper should be on an average of 2 to 5 degrees per wall or 5 to 10 degrees. You will find these figures given in the textbook of Marzuk and Studemont. This is classically asked in your orals as what are the concepts of a cast fold restoration. So please be minded that you must keep this point in mind. And then comes your line of draw. And the another important feature is the circumferential tie. Now, circumferential tie are all those elements of the preparation that brings your restoration close to the tooth surface. That is, it allows the adaptation of the restoration to your tooth surface. So they can be your skirts, flares, bevels, slices, all these elements of the tooth design that we make that will allow you to bring the different parts of the tooth preparation in close adaptation to the tooth surface. So they are the circumferential tie can again be asked as a short note. So it could be your bevels, flares, and it could be your slices. So the definition of bevel is any abrupt incline between the two surfaces of a prepared tooth, wall, and the cavo surface margins in the prepared cavity. As for an LAQ, so the type of the bevels, are the partial bevel, the short bevel, the long bevel, the full complete bevel, counter reverse bevel, and the hollow ground bevel. So you should know what are the indications of each of these bevels. I'm not going into the details. You will find this in the textbook of Marzuk. He has very well explained what are the indications. You can also later on refer back to this video, which is getting recorded for your reference. So what are the functions of these bevels? Again, a Viva question. Now it is mainly for the marginal adaptation to the tooth structure, the adaptation and burnishability of the cast metal margin to the tooth. It helps to eliminate or exposure of the cement lining between the tooth and the cast restoration. Can be aid in the retention. And the hollow ground and the contour bevels, they also improve the resistance form because they protect the tooth enamel, which has been weakened or which has been removed. And bevels are flexible extensions of a cavity preparation, allowing the inclusion of the surface defects or the supplementary grooves. So the tooth preparation, LAQ again, to describe the preparation and what could be the differences in the tooth preparation for the amalgam and the inlay preparation. So you need to understand that the basic concepts of the tooth preparation remain the same as that of amalgam. So I will just quickly brush through. That is the outline form, the initial depth, primary resistance, retention, and convenience form. The final preparation will again include all the steps of removal of infected dentin, finishing of the restoration, and giving additional features of retention and resistance that would be required. So removing all the caries defects, margin should be in the sound enamel tooth structure, and the consideration should be there if the cusp is weak, whether we should go for a cusp capping or not. The initial depth should be established at 1.5 millimeter. The facial-lingual depth, that should be 1/3 of the intercuspal distance. The facial and the lingual proximal walls must provide a clearance from the adjacent tooth of around 0.2 to 0.5 millimeters. Gingival margins of the cavity must provide a minimum clearance of 0.5 mm with the adjacent tooth. So an occlusal bevel will be around 30 to 40 degrees. That is 1/4 the depth of the gingiva, and the gingival bevel will be 30 degrees. So facial and lingual secondary flares could be given. These are for the indirect type of the wax patterns if it is required. Then the primary resistance form and the retention form. How do you get the resistance form? Now this is also true in case of amalgam restoration. So we give a flat pulpal flow, we give a box shaped design, we try and preserve all the cusps and the marginal ridges. So as far as possible, we are trying to preserve the natural tooth structure what is present. You give the resistance form, so you are trying to round off all the internal and the external line angles, rounding of the axiopulpal line angles, cusp capping wherever it is indicated, occlusal and gingival bevels. So the primary retention form is generally given by the occlusal dovetail that we are designing, and we give a 2 to 5 degree divergence, or the occlusal apical taper, which we are very important feature of cast restorations. And the secondary retention can be achieved by using the retention. So how do we get retention in cast restoration? It is by the walls that we are placing. So it's going to be the frictional resistance between the cast restoration and the walls, as well as it is going to be the additional cementation which we are going to use to cement the cast restoration to the tooth surface. And then there are features like your coves, hollow coves, the hollow skirts and collars and all that can be placed. So these are the steps: the occlusal punch cut, extensions, and cusp capping will be considered when more than half to 2/3 of the tooth structure is involved. We may not require to do a cusp capping, but when we see that there is more than 2/3 of the tooth structure that is involved, a cusp capping may be mandatory. So this is a proximal box, how we extend, removal of all the caries dentin. Dr. Singh has in previous presentation emphasized on the importance of giving the pulp protection and the tooth in deep cavity. So you can apply those similarly here. And the bevels and flares are the additional features that will help in getting the circumferential tie. So we have the occlusal bevel, gingival bevel, beveling of all the axiopulpal line angles, and the flare is your primary flare, your secondary flare, and a lingual primary and a secondary flare. So all these elements of the preparation help to bring the adaptation of the restoration close to the tooth surface. Now, again, a short note or could be an LAQ. That is the differences in the cavity preparation for a silver amalgam and inlay. The outline form in silver amalgam is narrow, which is around 1/4 of the intercuspal distance, whereas the outline form in an inlay is slightly wider. It is 1/3 of the intercuspal distance. In amalgam, the cavity walls, they are convergent or parallel or straight, whereas the cavity walls are divergent in case of an inlay preparation. The cavo surface angle is 90 degrees, or what we call it as the butt joint, whereas the cavo surface angle in an inlay is referred to as a lap sliding joint. The gingival bevel is 15 to 30 degrees in case of silver amalgam, and in case of the gingival bevel is 20 to 30 in case of the inlay. So again, the retention additional retention that we get in silver amalgam is by use of the grooves, the slots, the pins, and the secondary retention that we get in inlay is by giving reverse curves, collar, skirt, proximal walls, secondary flares, etc. Bevel is on a single, is only on the gingival cavus surface in case of silver amalgam. We don't give the cavus surface bevel because we know that it does not have the tensile strength. Whereas in case of inlay, the bevel is given on the occlusal as well as the gingival surface also, because we want the adaptation of the restoration onto the surface. Now we go to the next topic, that is the casting procedures. Definition: a procedure in which the wax pattern is converted to replicate into a dental alloy, introduced by William Taggart, and he described this as a lost wax technique. And the idea of the casting into a mold, he is the first to introduce the mold expansion compensation technique. Now, what are the steps in the casting? First is the wax pattern that is prepared. Then you go to your sprueing. Once the sprue is applied, the wax pattern is withdrawn. It is invested. After the investing, the burnout is carried out. After the burnout, it is the casting of the thing, and then we do all the finishing and polishing of the cast restoration. So what is an inlay wax? Which are the types of the inlay wax? What is the composition? And what are the properties of the inlay wax? Again, an important question. Please note, type 1 can be a medium wax or a soft wax. Medium wax is used for a direct technique and soft wax is used for indirect technique. Medium wax, when we say direct technique, it is the direct pattern which we take in the mouth. And when we refer to as an indirect technique is when we fabricate the wax pattern on the dies. So the composition of the inlay wax involves the paraffin wax, the carnauba wax, the candela, and the damar resin. So you can go through all the properties of that. You can again refer your anissoias for this particular thing. The important properties: it should have good thermal conductivity, high coefficient of thermal expansion, expansion of 0.7% with an increase in temperature, and it should contract when cooled, and it should not undergo too much of thermal changes, and stresses are going to be there. Therefore, again, that should be minimal and should have a good elastic memory. So fabrication of the wax pattern could be either by a direct method or an indirect method. As I said, it is prepared in the mouth, the direct method. The advantage here will be that you can get the exact control of the contact and contours in the mouth itself. You can check the occlusal pattern. And when it is the indirect method is when you have additional features which you cannot replicate with the wax pattern in the mouth, then you opt for doing your indirect methods, for which you can use a type 2 inlay wax. Sprue. What is a sprue? It is defined as a channel which is created in the investment, which the metal enters the mold space created by the burnout pattern. So sprue formers are the materials that form the sprue, and it may be made of wax, metal, plastics, or resins. Now, here I want to give you a little insight. I think these are the questions which you will find which are asked. And these are questions which are also very popularly asked on your tableside Viva. So please be mindful about that. And what are the basic requirements of the sprue? It should allow the molten wax to escape into the mold, should allow the molten metal to flow into the mold, and the metal within it must remain molten slightly longer than the alloy that has filled the mold. Therefore, it provides a reservoir to compensate for the casting shrinkage. So what is the role of a reservoir here? Is it compensate for the casting shrinkage? And what is a sprue? And what is its requirement? It allows the escape of the molten wax and allows the flow of the molten wax into the mold. So these are the three reasons why we require to have a sprue. What are the important factors of this the sprue, which one should consider? One is the sprue attachment. It should be attached to the thickest part of the wax pattern and at an angle of 45 degrees. A sprue diameter should be of the same size or as thickest as the wax pattern. It should not be too large, otherwise it leads to distortion, or it should not be too small, it will lead to premature solidification. So sprue attachment, sprue diameter, sprue length. Again, we should have the sprue length which should allow us to place 6 millimeter. It should be open from the upper end of the casting ring to allow the expansion of the gypsum bonded investment and for the escape of the gases. And it should be within 3 to 4 millimeter for the phosphate bonded investment. So we have two of them, that is the phosphate bonded and the gypsum bonded. So the gases need to be vented out from the investment. And a reservoir is again, as I said, to prevent the porosities. Now, crucible former, what is that? Crucible former, again, it is a conical base in which the sprue is attached along with the wax pattern and it is invested. It is like a concave depression, as you can see here, and it can be either of a rubber, metal, or it can be of any of different diameters and shapes. So casting ring and liner again is used. The types can be the metal rings, rubber rings, and the split rings. So the ring liner is allows the mold expansion. Therefore, it is lined within the rings which you are seeing. It allows for the mold expansion, reduces the heat loss, and it is easy to remove the investment after the casting is done. So these are the various reasons why we apply a liner. It could be of the asbestos liner, could be cellulose paper, fibrous ceramic aluminum silicate, or ceramic cellulose combination. Asbestos ring liner, not popularly used because of its potential hazardous properties. And we could also have the ringless casting system where it allows for maximum expansion of the investment, and it is suited for the casting of LOIs that require greater mold expansion. So these are again what are our Viva questions. What are the different type of ring liners? What are the ringless casting system? Now let us go to the wax pattern. When it is prepared, it has to be first cleaned and it should be invested as soon as possible. Within how long maximum you can afford to keep the wax pattern without investing? It is not more than 20 and 30 minutes before it is being invested. This is a very, very important diagram. So please make it a point to draw this diagram whenever there is a scope and a question that is asked on it, explaining the different parts of the mold. Now, investing procedure, as I said, gypsum bonded is indicated for investing your gold alloys on lace crowns. Phosphate bonded is for the base metal alloys, and the ethyl silicate bonded materials, we have it for your partial dentures and cast metal alloys. These are the various properties. They will have binders, modifiers, refractories. So you can refer the textbook again for these details. Investment procedure can be done by two methods. By either you applying, you can see in diagram 1, it is being applied with your brush, and or it could be by a vacuum technique, which is invested in a air-free environment. Next, we carry out is the burnout or the wax elimination. Now, it could be done by a low heat technique or a high heat thermal expansion technique. So it is advisable to, why do we do it is we want to flush out the wax and allow the metal to flow. So it could be a hygroscopic low heat technique or a high heat expansion technique. So gypsum bonded investment, you carry it out at a temperature of 500 to 700. Phosphate bonded, higher temperatures, that is between the range of 700 to 1040 degrees centigrade, and ethyl silicate bonded investment for ceramics is 1090 to 1180 degrees centigrade. So all of you should be aware of the range of the temperatures. In low heat, what are the temperature ranges? And in the high heat, what is the temperature? Gypsum bonded is for investing which type of alloys, phosphate bonded is for which type of alloys, and ethyl silicate. So now you got it, it is for gold, phosphate bonded is for your base metal alloys, and you have the silicate bonded for your ceramic restoration. So please be clear on that. Now the next question, how do you compensate for casting shrinkage? Because all the alloys invariably will shrink, therefore you have to make provision to compensate for that casting shrinkage. So how do you do it? The first is by the normal setting of the material, investment material itself, that is the linear expansion, and then it is your that compensates as one part of it, that is the setting reaction of the hygroscopic expansion that occurs between the investment material and the water that you mix, and then comes your the thermal techniques. So the hygroscopic expansion you can see is the compensation which occurs by immersing the investment in the water bath at 37 degrees. The warm water entering the investment mold from the top adds some of the expansion, and the thermal expansion at 500 degrees. So it causes 0.55 of expansion. So minimum and maximum setting expansion that can be compensated, it is around 1.2 to 2.5% respectively. Thermal expansion is when you are heating the mold, or the investing mold. So it is slowly heated at a temperature of 650 to 7 degrees for 1 hour, and above 7 degrees, gases like the sulfur dioxide and all get released. It contaminates the gold castings and makes them weak. Therefore, the gypsum bonded investment maximum expansion required is 0.5 degrees centigrade at temperature of 500 degrees centigrade should be attempted. The next step, what we carry out after we carry out the burnout, the next thing is now to melt the alloy. So for which we are using the flame to melt the alloy. So a flame has 4 zones. You are all aware: the mixing zone, the combustion zone, the reducing zone, and the oxidizing zone. Now, which is the zone of the flame which you are going to use to melt the alloy? It is the reducing zone. So please remember that. Now the casting machines, 3 different type of casting machines. We have the centrifugal casting machine. We have the electrical casting machine where your can be used for your ceramic restoration, and we have an induction casting machine which is again used for your base metal alloys. The direct current arc melting machines are the other machines which are vacuum or press casting machines, which are used for titanium and titanium alloys under vacuum arc or heated argon pressure casting machines. These are all the different casting machines that are available. Quenching is, what is this quenching? Is a process of rapidly cooling the hot casting by dipping it into water. Okay. So for noble metal, one casting is done, the ring is removed and quenched in water, and the button, when you heat the alloy, it appears like a red mirror, and you can it is an indication whether the alloy is cooled or not. You have your platinum based alloys and base metal alloys. They are not quenched in water. So we generally classically carry it out with your cast cooled alloys. Pickling. What is a pickling? Pickling is a method in which you try and remove the surface oxides which are present on the casting, and the surface, they appear very dark, and when you see the casting, it does not appear like a gold metal or anything else. It appears all blackish surface which you will see. So the best method to remove it is to use your solutions, which could be hydrochloric acid, sulfuric acid, or you could also use ultrasonic devices for this. Now you can also use your sand blasting, where you will use aluminum oxide, and you use around 50% sulfuric acid or hydrochloric acid for this pickling purpose, where the casting is dropped into the liquid. And after you finish with your pickling, it is clean. And then what you do is you are now going to remove the sprue, which can be cut by using your carbide bars, or you can use stones and discs, and then polish with tripoli or rouge, which is very important. Okay, so we finished with the casting procedures. Now the casting defects. A casting defect is usually an irregularity in the metal casting that is undesired, and some defects can be tolerated while others can be repaired and they cannot be eliminated. So as far as possible, if their castings are defective, we are not going to seed those into the oral cavity, but there are some things which can be rectified also. Now, what are the defects that occur are distortion, porosity, and incomplete castings, etc. Now, the distortion can be due to the mold expansion and due to the wax pattern distortion. So let us see here. So the distortion can occur because of the different reasons which are highlighted in the box here. I will not repeat them. So you need to, these are different steps which are given to prevent that, where you can use hard wax. Careful handling of the hard wax pattern during the removal. Separation should be applied to the die to ensure the smooth removal. Softening the wax at uniform temperature, and invest immediately after it is removed from the die. Now the next defect, surface roughness and irregularities. It is defined as surface imperfections. These appear as small nodules which are characteristics on the surface as air bubbles. You can see there on the diagram, and it could be caused because of the, it can be prevented by proper investing techniques and mixing the investment properly, application of a wetting agent, and a rapid heating are also the causes of fins and spines. Prolonged heating, it leads to decomposition of investment liquid to water powder ratio, and it can be prevented by proper proportioning of the investment. And then you have the water films. which can also lead to some surface irregularities. So you can use a proper ratio again and try and vibrate the mix to eliminate any of the air bubbles, etc. And foreign bodies, that is the incorporation of some foreign particles in the mold. They could be the pieces of the investment, or they could be bits of the carbon from the flux, or the sulfur components from the decomposition of investment. It could be anything. And therefore, the cause is the the casting pressure. If it is too high pressure, again roughness can lead to roughness. If it is too low pressure, can lead to incomplete casting. And carbon inclusions, again absorbed during the casting, results in formation of visible carbon inclusion. Therefore, pattern positioning again is very important when you are placing the pattern within the mold. Porosities may occur both within the casting or on the external surface. This is a very important question again, which is asked in for your short notes, or it could be your orals, or it could even be shown to you. Unfinished casting can also be shown to you, and you could be questioned on all these lines. That is, what do you see on the casting surface? Can you enumerate the reasons? How are you going to prevent it? So this is the way in which you are likely to be assessed for this thing. So porosity is due to metal solidification, porosity is due to the trapped gas, and porosity is to the residual air. So due to the metal solidifications, we have the localized shrinkage porosities, which is caused due to insufficient molten alloy, long and thin sprue, and low casting. And the remedy is to use a sprue of correct thickness, proper attachment, placing a reservoir, flaring of the sprue at the junction of the attachment, and reducing the mold temperature. Suckback porosity. Again, classically asked question. The different type of porosity, like your suckback porosity, hot pot porosity, pinhole inclusions, are very commonly asked question. So please pay good attention to this part of the presentation. If the sprue is attached at 90 degrees, the molten alloy enters the mold space and directly hits on the opposite wall of the mold. And this results in the formation of what is called as the hot spot. So during solidification, the metal near the hot spot solidifies first. And due to this, there is no extra molten metal left to compensate for the shrinkage. So that has to be prevented by proper attachment at 45 degrees. Micro porosities, again, are irregular voids within the material if the solidification occurs at improper temperatures. Therefore, it is not a very serious defect, and you can increase the mold temperature. Subsurface porosity, again, whenever you are in too much of a rush and you're trying to attempt something, it could lead to the subsurface porosities. Porosities due to the trapped gases are the gaseous porosities within the molten alloy, and on cooling, the alloys liberate these trapped gases but remain trapped within the alloy, becomes rigid. Pinhole porosities. So you can refer all these slides, and you have the gas inclusion porosity because of the inclusion of the gases. And porosity is due to the residual air. What is back pressure porosity? Is caused due to the inability of air and other gases to escape out of the investment, making a way for the alloy. So that is referred to as the back pressure porosity. So it could be because of the clogging of the mold, increased distance from the mold, and inadequate casting pressure or dense thickness. So prevention is you have to give proper venting, use of a reservoir. End of the ring should not be completely covered in any part of the casting procedure. Dense layer of the investment material should be scraped out to facilitate the escape of the gases, and thickness of the investment from the above surface should not be more than 3 to 4 millimeter. Incomplete casting occurs whenever there is inadequate amount of molten metal entering into the mold. And incomplete casting. So this is a table where you will see the procedural errors, the type of the failures, and the solution. So this can be asked as your question. So this table is very important on that front. These are the same points which I have discussed, so it will not be repeated. Let us move ahead. We go to the next topic, that is the dentin bonding agents. It is adhesion is derived from the Latin, meaning a state in which two surfaces are held together by interfacial forces like the valence forces or interlocking forces, or both. And the three important components comprise of the adhesive, the adherent, and the adhesive strength. Adhesive, it is defined as a material, frequently a viscous fluid that joins together by solidifying, resisting separation, and transferring surface to the other. Adherent is defined as the surface to which the adhesive adheres, and the adhesive strength is the measure of the load-bearing capacity of an adhesive joint. Mechanism of adhesion is by adsorption, diffusion, or it can be mechanical. We have the enamel adhesion and dentin adhesion. Enamel is hydrophobic in nature. Dentin is hydrophilic in nature. So these are different substrates on which the adhesion is always going to be challenging. So in enamel adhesion, you know all that we carry out the acid etching, and then we apply a fluid resin-based material onto the surface, and then these monomers in the material are polymerized, and this forms the interlocking. The etching pattern, there are three types. Which are the types of the etching? Again, a question that could be addressed in your orals. You have your type 1 etch pattern, type 2 etch pattern, and type 3. So it is the prism structure, in which the type 1, you will see the dissolution of the prism cores without the involvement of the prism peripheries. In type 2, peripheral enamel is dissolved, and in the type 3, it is less distinct than the other two patterns. Etchant, generally, Buonocore, he advocated the use of 30 to 40% phosphoric acid. Classically, we use 37% phosphoric acid in a gel form, and because more the concentration calcium salts are less dissolved, and lesser than 27%, it leads to formation of dicalcium dihydrate. It cannot be easily removed by rinsing. Therefore, you need to use a proper concentration of 37%, which is recommended. And the etching time period is 15 seconds. It does not make point to etch more. Now here you could be tricked as to a question as to what about the teeth in which there is which are having the fluorides. There the etching time is definitely increased for 1 minute, where it takes a longer time because whenever there is fluorosis. So however, in the other cases 15% should be a good enough time. So now let us come to the dentin adhesion. Why it is different, enamel and dentin adhesion, is because dentin is a wet structure and it is a moistness which plays a very important role that does not allow the adhesion. Therefore, it is always going to be challenging. And let us see what are the challenges. The question here that could be asked is, what are the challenges that are faced in dentinal adhesion? So one is the structure of the dentin. The second point is the smear layer, and the third is the stresses at the resin-dentin interface. What is a smear layer? Smear layer is a residual organic or inorganic components which are formed when a tooth is prepared using a burr or any other instrument, and it is around 1 to 10 micrometers thick, and it comprises of, according to the SCM studies given by Schulin in the year 1988, he says that it comprises of small particles of mineralized collagen matrix, inorganic tooth materials, saliva, blood, and bacteria. According to Brandstrom, the organic component comprise of the coagulated proteins from the collagen, which is denatured by frictional heating of the cutting. That is when you prepare your tooth. So dentin bonding agents is defined as a thin layer of resin applied between conditioned dentin and the matrix of a composite. So the term dentin bonding agent is no longer relevant as current bonding enamel and dentin. So we are using it to bond both the enamel and the dentin. And due to acid etching, micro leakage or loss of retention is not a hazard. Enamel interface which is encountered at the resin dentin interface. Due to the difference in the composition of the enamel and dentin, it is very important that we develop the we have to understand the challenge that is going to be there. That is a high water content which is going to interfere with the bonding and presence of smear layer on the dentin. So dentin bonding agents, it is here we said it's a thin layer that is has been applied, and due to acid etching, micro leakage, enamel surface, but it is encountered due to the differences in the component that will adhere. You can see the composition here, presence of smear layer on the dentin. So a bonding agent should be hydrophilic to displace the water, permitting it to penetrate the porosities in dentin and react with the inorganic organic components. and the restorative resins are hydrophobic in nature. Therefore, the bonding agent should contain both the components. And the hydrophilic part binds either to the calcium or collagen, whereas the hydrophobic part bonds with the restorative resins. Now, what is that layer called as? It is referred to as the hybrid layer. So, mechanism of the dentin bonding. So, you do an acid washing, you remove the smear layers, it removes the hydroxyapatite, then it shrinks your collagen, and again we apply a primer to rehydrate the collagen. That leads to the swelling of the collagen, and the collagen becomes more stable and the bonding can be carried out. It's not going ahead. Yeah, so these are the different generations of the bonding agents that we are having. The first generation, second, third, and up till the seventh generation. As you can see that there were 1-step and 2-step etching. The earlier generation of the bonding agents, which did not have help us to achieve adequate bond strength, and it was very weak strength. And therefore, what we see is the fourth and the fifth generation are having good bond strength, and then we have the sixth and the seventh generation, which are the self-etch priming. These are the we need to look into that. Correct options for the resin dentin bonding. Adhesive strategies. So in the different generation of bonding agents, you have these combinations. It is not the scope now to discuss all this. So I'm just moving ahead. Factors affecting the adhesion is the wettability. Wetting is an essential part for the success of adhesive mechanisms, and adherent micromechanical interlocks nor the chemical bonds with a surface unless it can form. Yeah. So wettability of a liquid on a solid can be characterized by the contact angle. So here you can see there is a good wetting, partial wetting, and a non-wetting. So you have a low surface tension agent. You can see in the first diagram here, it leads to good wetting. And in the last diagram where you see a good spear, it shows the non-wetting. That means there is no flow of the there. So the surface energy is very important. So by cleaning by pumice or prophylactic paste, etching with mild or strong acids, or cleaning with solvents to remove the contaminants, you can increase the surface energy so that it will become more receptive to receive the adhesion. So you can see the high surface energy, it is totally flattened out, which indicates that it is properly adapted. So you have the surface tension of the adhesive, low surface tension, adherent, high surface energy, hydroxyapatite and glass ionomer cement, high surface energy, collagen and composite, low energy surfaces. So these are the different substrates on which the bonding has to be carried out, and surface roughness of the substrate. Cleanliness of the substrate is again very important. Viscosity of the adhesive, if it is too viscous, it will not flow, and it is very difficult to achieve a micromechanical retention. So if the adhesive has to be adequately flown, and you can slightly blow dry with the air to allow it to flow. Dimensional stability during setting or during the curing, and the durability of the bond is very important. So once it is applied and after it is cured, it is very important that the interfacial bond remains adequately in for a longer period of time. So we go to the next topic, that is dentin hypersensitivity, asked as an LAQ, or maybe a part of it again, most commonly being assessed for your short note. Dentin hypersensitivity characterized by a sharp short pain which is arising from the dentin in response to typically a thermal evaporative stimuli, osmotic, which cannot be ascribed to any other form of the dental defect or pathology. So what is the difference in this and a pulpitis is not having any pathology which could be contributing factor. The differential diagnosis could be a chip tooth, could be a reversible pulpitis, or it could be because of the leakage around caries, tooth, etc. So the clinical features commonly affecting the adults, more common in the age of 20 to 40 years, higher incidence in females. Hypersensitive teeth are a source of chronic irritation that affects eating and can get very sensitive even when you're breathing, giving a lot of discomfort, very vicious cycle. You will see mostly in the buccal cervical area. The common sites or the predilection where you will find them is in all these areas, and it is not having a correlation with plaque, but nevertheless it's not good to have plaque also. The etiology could be because of the gingival recession, tooth brushing, gingival recession which occurs because of the gingival condition, that is your anug and anop. So you have your periodontal diseases, periodontal surgical and non-surgical procedures, or the dehiscence and fenestration type of defects where there is a loss of the cortical bone, exposure of the root surface leading to dentinal hypersensitivity, loss of enamel, again attrition, abrasion, improper brushing, erosion, or a gastroesophageal reflex that could lead to erosion of the tooth. So these are not the commonly common reasons which could be responsible for it. Then you have the theories of the dental hypersensitivity which have been implicated. You all know that is your direct nerve theory, your odontoblast receptor theory, and a hydrodynamic theory. The most accepted, which you all know, is your hydrodynamic theory, which is because of the fluid movement and the stimuli that is applied to the pulp and movement of the fluid materials into the dentinal tubules. Now let us come to the management. We have the treatment management, which can be by the it could be by the patient himself, that is the home care. It could be in-office treatment, or it could be the patient education. So in home care, it could be using the desensitizing agents like your strontium chloride, your potassium nitrate. And at home management, you can ask the patient to use it twice. So please remember, and you also do not forget, in case sometimes you have a discomfort, you can also, you may not afford to forget it. And you will find that most of your uncles and grandfathers here and all, they will always complain that they have a sensitive tooth. So please be mindful of these agents which you can prescribe them. And in office treatment, you can attempt to do the remineralization, and you could be using with the help of using the fluorides or the CPP, ACP agents, that is your casein phosphate peptide. Amorphous calcium can be used for the treatment. You could use your adhesive materials. They could be use of varnishes, bioglass, lasers, and oxalates. So these are the different managements which can be carried out in the office. All of you must be versed with all these management strategies. And then of course the patient education and counseling will be important. You will do a diet counseling. You will ask them to advise them to do a proper brushing techniques. Plaque control and presence of the plaque will definitely interfere with the mineralization process. Therefore, it is very important to maintain the hygiene. So you have to advise a good prophylaxis so that these things you can carry out. And then we go to the next topic, that is advances in endodontics. Now, in advances in endodontic, most of you will be aware of all the steps that you are carrying out. You know, it's a classical triad. So I would like to just highlight only what you could additionally add into this. So let us take it into the technological aspect. That is, let us come to all the diagnostic procedures. That is, we are going to discuss it in advances in diagnostic phase, in instrumentation, use in magnification and ultrasonic, advances in the irrigation methods and the disinfections, in the obturation, advances in the surgical surgical modes, bioceramic material, lasers, and the biological aspects. So this is where you will see all the advances. So apart from all the routine conventional methods that you carry out for your diagnostic process and your pulp testing and examination, we have the digital radiography, pulse oximetry, uses probe camera, liquid crystal testing, and laser Doppler flowmetry. Advancing in instruments is apex locator, instruments, nickel titanium, and instrumentation methods like, and you have your apex locators, 4th generation of the apex locators. New generation, you have the which are based on dual frequency and wavelength. Instrumentation, you have the super elastic nighttime material. So those are the advances. And like your pro taper, which have increased flexibility, different type of cleaning and shaping files, as well as your techniques, we have advances. And then the magnification and the ultrasonics are other additional things which you all nowadays hear about and are very intrigued and maybe very fascinated by this magnification and use of microscopes in endodontics. So those are, we have the loops and all the procedures that we are carrying out under magnification. Use of the ultrasonic tips are very important, which we use for access opening. These are the tips which you are seeing here, ultrasonic tips which are used for the initial access openings and for your surgical procedures. And you let us move on to the advances which we have in the irrigations. You have the combination of MTAD, and we have different irrigation activation systems like your IriSafe and Endo activator, MaxEye probe, and different delivery system and agitation systems, which are briefly noted there. Obturation, we have the thermoplasticized obturation techniques, and these are very popular. Apart, and this is again in obturation, again an important question that will be asked. So you could also include from additional vertical and other methods of obturation which have been explained. You could also add additional thermoplasticized methods in that, and advances in surgical methods where the use of microscope and magnification has become very important. Use of the ultrasonic design tips for your retro end preparation. Use of different materials like your ceramic materials, MTA and biodentin for retrofilling. Your ceramic materials, we have your MTA again, which is very frequently used for repair of all the perforations as a root end filling material for epexification as well as your regenerative endodontic procedures. Lasers in endodontics, another advance which is used for disinfection procedure. Basically the application is in disinfection and in apical surgical endodontics could play a very important role. For regenerative endodontics, we have different materials and there are a lot of other things which you will read about the tissue engineering, different types of stem cells and scaffolds. So you could attempt these questions on these lines. We coming to the obturation, which is the most important topic again in form of your LAQ short notes and Viva and almost everything. This topic is again important from your exam point of view. So what is obturation? It is a three-dimensional filling of the root canal, as is commonly said. So the American is fill and seal a shaped root canal. Now, when to obturate, what are the criteria to obturate the root canal? These questions we also typically write in your journals, which you all write. You must have all this on the tip of your tongues. What are the criteria that you will consider when you obturate the root canal? That the canal should be ideally clean and shaped to an optimum size. It should be dry. It should be asymptomatic. There should not be any pain. And the previous criteria that were said were there should be a negative culture and there should be no absence of foul odor and lack of apical sensitivity. But of course, the negative culture tests we do not follow it. But you must know all these criteria as to when the tooth is ready for obturation. And what should be the extent to which the apical obturation should be carried out is around 0.5 to 0.7 millimeters. So overextension, underextension, both should not be done. Now, what is this diagram which is shown here? It is the classical this Cutler's study, which describes about the apex of the root around 0.5 to 0.7 millimeters is the very critical junction. You should not lead to overextension or underextension, and it should terminate at the minor constriction. So that is the limit and extent to which you should have your obturations. Ideal requirements, you all know the gutta percha. It should not be irritating, should fill, should not shrink, should be impervious to moisturizer, bacteriostatic, etc., etc. And these are the different type of the materials: solid core filling, paste, and filling materials. Gutta percha is one of the most commonly used. Composition having classically your zinc oxide waxes and your metal oxides. The important properties which exist in beta form, and when it is plasticized, it turns into the alpha form. And how do you plasticize the Yeah, so how do you sterilize the gutta percha? That is, you can dip it into the isopropyl alcohol and it can be sterilized, or they're available in pre-sterilized package. So these are type of questions which are generally asked in your orals. Then how do you identify what is the availability of the gutta percha, in which form they are available, in commercial forms, in injectable forms, in different sizes, color coding, medicated gutta percha. These are the different techniques. Enumerate the techniques of obturation and describe one of the obturation techniques in detail is a classically asked LAQ technique. Max Pidden is again a thermomechanical compaction, which is asked as a short note. These are all the different methods. And you could highlight upon all the different steps about the selection of the gutta percha and how you do the trial of the master cone, how you apply the sealer, how you select a spreader and apply. So that could be all included. A good diagrammatic representation is what will be very important. I mentioned to you in the very first method, in my very first beginning itself, I have explained you that. Now we go to this topic, that is the endodontic surgeries. What are the, this is again a question which could be asked as a LAQ. So, and maybe the questions that generally you will find which are asked on this topic are the indications, the contraindications, and there could be an episectomy or epixification, or there could be a retrograde filling. So these are the general things that can be asked in this particular chapter. So the indications you can see, that is a need for a surgical drainage, failed non-surgical, metamorphosis, procedural errors whenever there are anatomic variation, biopsy, corrective surgery, and replacement surgery. So the contraindication could be relative or absolute. Incision and drainage. What are the different type of the procedures in the endodontics? Yeah, this is a little elaborate, so I am just going to skip through all of this. I have not much time. But anyway, it will be it will be recorded, so you could be referring to it, the video. So you all know the steps. There are the incision, there is a flap reflection, different types of the flap. Then there is your osteotomy, and after you after you do the osteotomy, then you go to the periradicular curettage. So there you, after it is done, the next step what you will perform is a root end resection. Now this can be asked here, in which all cases will you do a root end resection? I have put in the indication and contraindication, and you can attempt to do the root and cavity preparation, or what we also call the retrograde filling under magnification. MTA could be used, and if there are large defects, you could also place some bone graft material. Another short note could be a hemisection. It is again an endodontic surgical procedure where you are converting, or also referred to as bicuspidization. So with this, I conclude my presentation. Yeah, again, I think I am almost in time, though I did rush through in the last chapter. But I would request you all to refer back to your textbooks. And what is important is already I have briefed you. So please try and make an attempt to read. And I wish you all the best in exams. I know this year has been really very... it's been a real tough time, and the hot burning environment of the pandemic is on. And I hope that you students who have missed out on attending classes and clinics will make use of this, and it will be helpful to you. Wishing you all the best once again, and hope you will all do well. Thank you.
Hello, thank you, ma'am. Thank you very much for your detailed explanation about all the topics and encouragement for the students. Very thank you much. And now I'll introduce the next speaker, who is Dr. Vivek Hegde. I don't think so he needs any introduction. सिर्फ नाम ही काफी ऐसा बोलते हैं. He is a professor and head, Department of Consultative Dentistry and Endodontics, Ramanwala College. He is also the vice principal and one of the well-known speakers in the field of endodontics. So, sir, it's over to you, sir. Please.
Thank you, Kishore. Those were kind words. I know the students have been sitting for a long day. It's been 4 long hours from some of the good, eminent, prominent speakers and teachers, academicians, educators. I've been given 1 hour, or actually 50 minutes, to also cover on some important topics, exam oriented. First of all, before I begin, I'd like to thank the MUHS, the university, for which we all belong to, and the team of speakers, the coordinators, who all have been responsible. Actually, I'd like to mention Dr. Abrar Syed here. I think he has been contacting us literally every other day for the last couple of days to, get us together. So thank you, Abrar. I know you have to leave for a small meeting again. So what we'll do today is, with the permission of Dr. Abrar, I was just discussing now, and I said, I will go a little clinical on these topics, in the sense that whenever a question comes to you, let it be a short note or a long question, you have to correlate it to the clinical situation. That's exactly how it goes, in life. Like we do a lot of, I know you're an undergraduate student, and why are these studies done? We have these studies that we compare some two groups and make a report out of it, right? We mostly take in vitro, it's outside the mouth studies, outside the body studies. There's something called in vivo or in vivo, which is inside studies. So most of that studies are in vitro. They're called bench stop studies. About 60 to 80 or percent is all bench stop. And then when that passes, we go into animal studies, and then we go into clinical studies. So that's how it goes. So basically what we're trying to do is we have to simulate it to the oral condition. Whatever we take up as to work on, we simulate to oral condition. Similarly, when a question is asked, if you can simulate it to oral condition, like maybe I'll be speaking first on a topic like, say, okay, biomechanical preparation. What does this mean and why? If you can correlate it to clinical condition and try to understand rather than by heart or mug it up, then I think things become much more easy. The first and foremost thing what an examiner will expect from you is, have a good flow chart. It's very, very important. Nobody is interested in long stories which has no meaning. I'm sure the earlier speakers also mentioned the same thing. I will also say the same thing. I will tell you, construct yourself. That itself speaks volumes. As a student, I was not told, so I was a storyteller. I used to go writing stories after stories, and I sometimes got less marks. Of course, you can't expect the marks to be like mathematics, because there's no end point here. In science, you get a grade, you get a percentile, you get a percentage. You don't get 100%, right? That's fair enough. But I wanted to get the workflow. So whenever you get a paper, the first thing is, I want you to read the paper well. Read it twice. Be like a carpenter. We are referred to as barbers or carpenters because of our tools that we use, right? But what does a carpenter do? He will measure it twice, but only cut once. That's exactly what I want to do. I want you to read the paper twice. Write once, but read it twice. Because sometimes in that mood that you're in, you may not write it well because you read it wrong. The question that needs to be written, so many times when we ask a Viva question, when we ask an oral question, or it may MCQ, or a short note, or even a long question, the gist of the matter is lost. So try and understand what the examiner has asked you or what the paper demands. That's all. And write to the point. Believe me, every examiner will give you the same amount of mark, be it a smaller paper or a longer paper. If you have covered all the points, like you have good flow charts, you have good pictures, good diagrams, which are diagrams are well put up, very self-explanatory, they're very, very legible with a good highlighter. These are all very, 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 very important things. So I want you all to do this. When you read the paper, I said read twice. Every one of us know, including us, that all the questions we may not be good at all the time. There are some things that are your favorite, some things are less favorite, and some things are least. Whatever is your best, write them first. Because the question that you don't know well, if you waste time, and the question that you know best, you'll not get maximum marks because you didn't have time. So write the first round with the best questions you know. And if it flows the flow chart of the paper, excellent. If not, write again what you know best, go back, see second best, and then the things that you don't know. Because the things that you don't know won't attract much marks anyways, right? So that's okay. But at least where you can score, get them first. That's what I want you all to do. So try and get this habit in yourself, and do not waste times on those that you don't know, right? So we will do one thing. We will do a skeletal for this particular topic. So if you see this biomechanical preparation, I want all of you, I'm sure I'm not going to give you notes of each topic. I'm going to give you a lot of clinical pictures and videos and some demonstrations maybe, but I'll give you a flow chart. Suppose a question comes on BMP. What will you write? In fact, it's not called BMP anymore. It's called cleaning and shaping. Sometimes there's shaping and cleaning because you have to shape first and then clean next. We'll talk about all that things. But the most important thing what you need to understand is structure your answer, for which, for me, it starts from introduction to conclusion, whatever the headings that can come. So I was just sitting on this question and I said, let me write my way, you know. So I'm not going to give you other ways because I'm sure all teachers from your respective colleges have given you good notes. You can also borrow notes from each other's colleges, follow them, read them, get it from any literature that you can get. But I want you all to understand how to write a paper. I would have written an introduction that is like you're introducing a subject. You need to always do that. You need to introduce everything first. And then you write why. Every study or every question will have aims and objectives. Aim is just one most of the time. Objectives are many. What is the reason behind the question being asked? What do I need to write about that question? And then you can go into the principles for this topic, of course. Then you can go to the terminologies. You can go into the motions of instrumentation. You can go into the working length determination. You could go into techniques and maybe conclude it. In some other classification and some other question, you may have a classification to write, advantages, disadvantages to write, pros and cons to write, whatever it may be. So when you get a question like this is what I would construct. This is my constructing, because for me, it's all about readership. I want to read it well. If I've seen that the student or the participant has written the flow chart so beautifully, has given me beautiful pictures, has labeled them well, have put a good sketch of the flow chart, I know he knows the answer well. Even though he has not got enough time, I will be for it. It's that way, you know. I'm sure all the speakers, I mean, the examiners will think the same way. So please try and understand this much. Now, when it comes to introduction, what do you want to write about introduction? In introduction, of course, what is BMP? Why was it called BMP? First is what is called chemomechanical. There's a lot of chemicals involved, then mechanical happened. Then it became biomechanical because biological aspect came into the mechanical aspect. Today they say, let's not make it as only biomechanics. Let's call it as cleaning and shaping. Actually, truly speaking, shaping and cleaning, but if you don't shape, you cannot clean. So the whole concept has changed. These are all newer words that's been mixed up and used up. You can call it a misnomer. You can call it as the right word to be used. That's your wish. First thing is about introduction. Give it in a small paragraph, apt and brief. Don't make storytelling to the point that if you don't know an answer, it's a different thing. But if you know an answer, I want you to give the good story to the point. Second point will be objectives. When you talk of objectives, you need to say, why was it asked? What are the objectives of cleaning and shaping, or shaping rather? It are two things. One is mechanical, one is biological. What are the mechanical objectives? That's what shape it demands. A smooth flowing curve, rounded angles, a flare on different levels, keeping them, apical diameter as small as practical. You don't disturb it. Follow the inner and the outer, respecting diameters and the walls and the flow of the root. These are all the mechanical objectives Herbert Schilder gave us, right? Now there are something called as biological objectives. Why do you have to enlarge the root canal? It is true that when you clean with, say, hypochlorite or with any other chemicals, it removes a lot of bacteria from the canal. But remember one thing, for your needle to go inside there, for you to irrigate that place, you have to shape, otherwise the needles don't go. The thinnest needle is about 30 gauge. And the 30 gauge needle has to go in to the deepest portion, that is the apical end. In the roots, you have three ends, right? You have the coronal end, you have the middle, and you have the apical end. At the apical end, if the needle has to reach there, you have to prepare the end to a good diameter. So now you understand there are three things to remember in this root canal. One is called the length. That's called the working length. We'll come later. You have no choice. You have to enlarge till where it is. You can't be short. You can't be beyond. Second is called a diameter. End of the root has got an exit. That's called the minor diameter for us. But now it's infected. So we need to enlarge it to a certain diameter. If you have read Grossman's principle, he said, let us enlarge the diameter to about 3 sizes. Now, this was just a concept. It's not a must now. You may do it 3 times, you may do it 2 times, you may do it 5 times. You clinically decide that. But you need to understand what it means. So you're enlarging the diameter a few times more, only because to get a biological concept, which means you want to bring the dentine, which is infected on the inner wall of the root canal, to an area where it's non-infected as much as possible. That's why you enlarge it, say the initial apical file to a master apical file. That's 3 sizes. Initial apical file is the first file that binds the root canal from the entry point till the very end, till the prescribed point. That's a snugly fitting file that goes to the full length. It's called the IAF. It's an initial apical file. Now, old literature demands that you have to do it 3 sizes more. So if the 10 number file, a K file, is binding tightly, we want you to enlarge till 15, 20, and say 25. So you'll stop at 25. Fair enough. In the newer concept, the whole thing has changed because argument is very simple. They say, suppose I enlarge till 25, what guarantee do I have I get clean canals? Or sometimes I don't need 25. I can be lesser than that and still have clean canals. Both arguments are correct. It also depends on is the tooth vital or non-vital, infected or non-infected. So that theory is a separate topic. We're not going there. I just thought I'll give you a little clinical perspective why these two objectives existed, a mechanical and a biological. Biological because it is not only because of irrigation that the bacteria go out. When you do a cleaning and shaping, mainly shaping, a good amount of bacteria gets out because of the dentin debris that gets cut and you're washing it out. So mechanical is still there, but it's called a shaping. That's what you should understand. So then comes principles. What are the different principles you want to think about? We'll just stick to Cohen. There's crown preparation, root preparation. Root preparation was called as radicular cavity preparation. They spoke about terminologies. Now, different terminologies have been used. Now, we'll just cover a few of them. I just picked up some clinical slides to explain them better, like a pre-curved filing, maybe apical patency, a glide path, a recapitulation. These are the words I saw in the books. I know I'm speaking to undergraduate students. I know I'm speaking to young minds. But if you understand this well, I think and these points are kept in your mind. Constructing a paper, writing an answer should not be a difficult thing because this is absolute a clinical thing. If you go into some topics which are non-clinical, where there are formulas, I know you may have to mug up, you may have to buy hard, you may have to study it a very, very different way. Okay. So the next point, we'll come to these points one by one in a clinical example a little later. Motions. When you talk of motions, you need to understand again, what are the motions of instrumentation? The oldest motion was called reaming. You type into Google, type into any dictionary, ask what is reaming. One of the meanings will be you're reaming a root canal space. That's how close reaming was mentioned. Basically, you're drilling into the space to remove the dentine. Okay, filing. Filing is what you're going in and out to again cut dentine. Then it came circumferential filing. Then there is watch winding. There is balance force, envelope of motion, whatnot. We'll see if time permits, we'll cover them. Working length is another important topic because you can only work till where you can go. Like I said, this first it was length, then was diameter. Third is known as taper. Taper is less important when it comes to length, diameter, and taper. Length, you have no choice. Diameter, you have less choice. Taper, you have all the choice. Do you want to make it a big flare? Do you want to make it less flare? Choice is yours. Follow whichever concept you want, everything works. And finally, when you've written this paper, you need to conclude the paper saying that, yes, the justification of these explanations was these. That's how you close the paper. That's a concluding remark. So always an opening statement and a closing statement is very important in any construction. It might be a write-up, it might be a speech, it might be anything that you think of. So start making it as a habit in life to make this as a skeleton, as a structure, as your flow chart for anything that you want to do. It makes your life more disciplined, more organized. So for biomechanical preparations, I thought of these. You can still add more, I don't mind. But again, you think, what was the question? Was it a short question? Was it a Viva question where only one point is picked up? Or is it a long question where possibly you have to write an elaborate thing? Then I may add some more in this. I've not gone into everything, like recent advances or anything that can come. So speaking of biomechanical preparation or cleaning and shaping, with respect to shaping, there are a few points that are mentioned here. We'll take up them, like glide path. So if you see here, what do you mean by glide path? Again, as undergraduate students, don't get confused. Don't have to worry about all this much. But glide path was a concept. You know why it came? It came because X-rays are 2D. The radiograph that we take are 2D pictures. And tooth is a 3D. So what we need is, we need to work in a 3 dimension or a 3rd dimension, which we cannot see. So to get the glide path, when you make a radiograph, you can see the right and the left, that is mesial and the distal. You can see the down and the top, that is the crown and the root. But you cannot see the in and the out. Okay, that's the 3rd dimension, which means you cannot see the cheek and the palate. That's the 3rd dimension, for which sometimes we need CBCT, like a scan, like a 3D. I'm not going there. What you need to know simple is, what is a glide path? Glide path is nothing but you need a hand file which will travel from the entry point of the access cavity till the end of the root canal in a smooth fashion, repeatedly, passively, systematically, every time. And that's what is needed. And preferably a glide path file should be a stainless steel file, because I want a reproducible glide path. I want to register the impression of the canal. Because when you take the file out, when it curves palatally, when it curves buccally, the file, when you take out, it shows me the direction of curvature, which never comes on a 2D, never comes on an X-ray, never comes on a radiograph. That's what glide path will teach you. So what you need simplest is the smallest file. When I say smallest, of course, you will argue and tell, yeah, 6 is small, 8 is small. Correct, it's small. But the standard file that 10 number offers you with resistance, the others don't. So I need a 10 number file to go up to where you can go, if possible, to the full length of the root end that's here. That is known as a full glide path, a passive glide path. It has to be a super loose number 10 file. That's how it is. Now, if that you can get, I think the root canal becomes easy, because you know the path, you know the direction of its travel. It might be a short canal, long canal, curved canal, narrow canal, wide canal, straight, anyway, or a block canal. So you know, you get an idea of how to work. So they are called scouter files, like the number 10 file or the small files are called scouter files. Like I said, it's for undergraduate I'm talking, so I don't want you all to get worked up with all these references. But these are the people who develop these concepts. The good clinicians, Richard Munns, or your Cliff Ruddle, or John West, they are the people. So I'm not going to read the slides here, but what you need to understand is, you need different types of files for different cases. Now, every root canal may not be simple. Some may be simple, some may be a little difficult, some may be not very, very difficult. So we'll classify them as simple, not so simple, or not at all simple. So different types of files to get the path inside. So these are hand files. In the earlier days, we did root canals with only hand files. We put a 10 till the file becomes loose. We took it out, washed it, put a 15, again did it, put a 20, again did. We went on doing it till say 40 or a 50 or a 60 number size. 60 is nothing but 0.60, the 60 size apical diameter, a 0.6 cross-sectional diameter at the apex. But these were all hand files called 2% files. Leave it at that. I'm just trying to give you a concept. Because I told you a steel, you can pre-curve the file. So when it's a hand file, you can, don't write as a night eye, please write as a steel file. Even though you get night eye, that's not for routine endodontics, it's for something else. Okay. So you pre-curve the stainless steel file and we'll use it in the root canal. There are 10 number files you can pre-curve like a hockey stick pen, and just for you all to see a small video, you're pre-curving it and then introducing the root canal to negotiate the root canal. Because it may go into a strong lateral canal like the way it's going here now. You see here, it can go into the nooks and the crannies of the root canal system like the one that's there. It can go into the hideouts, it can dislodge tissue tags, many things can happen. So this is nothing but a recapitulation file. In our times, we are told recapitulation is a big word. For us, recapitulation was a file smaller than the bigger file. It was not told it is 10 number file. It can be any smaller file than the last file. So even now we follow the same concept. But what we do is we put a smaller file before the larger file and after the larger file also. And for me, there's always a 10 number file, a stainless steel file, a pre-curved file where I can go to full length and try and tease and tickle the canal. Because it dislodge the tissue tags and try and take them out. You wash them nicely. That's called a pre-curve filing and take. So you will have to know these motions. In the books it was given, I saw this, that's why I put them here. You have a motion called watch winding. What does it mean? Olden days, we had this watch where you used to give a twist, it used to go clockwise and come back that way. It's a 30 degrees turn, forward, backward motion. So we see this video now, see this. The stopper is facing you, you're only teasing and tickling the root canal to take it to full length. So you're just doing that much. So that's known as a watch winding motion. So I want you all to understand to go till there as a watch winding motion. So slowly start teasing and tickling it that way. 30 degrees to the clockwise and 30 degrees the counterclockwise. Now you have something known as a balance force motion. In a balance force, you do the same thing more. You do 90, give it an apical push, and then pull it back. So that's how it goes in a balance force motion. So 90 degrees, apical push, 270 reverse, and then you pull it out. Wash it nicely. Again, introduce a file. Cutting is 90 degrees because all files only cut forward motion. Remember this much. Let it be hand, let it be rotary, except on a reciprocation motion, which is a different concept. And then you have another motion called as envelope of motion, or okay, we'll call it push-pull. Push-pull is nothing but a short strokes of push-pull that you do till you go there. This is not the best motion to do in a root canal, especially when you're at the apex. I don't want you to push things beyond apex. I want you all to be very, very, very clever and clear to do that. If you understand these concepts, writing a paper becomes very, very easy. Just try and correlate it there. And then you have something called as envelope of motion. I didn't know if this was important for an undergraduate, but this is how you do it. You turn the file, a pre-curved file at the belly of the file so that you enlarge the canal above a canal if it's a block canal, so that you prepare it well. So this is how it goes. See this? There is a file, there is a gradual curve, and in between, in the belly of the file, there's a curve, and that is touching the wall to enlarge the canal bigger. So you should understand few motions of instrumentation, because you may get a question. I've seen in one of the universities, motions of instrumentation was a question. So you write all the motions of instrumentation. So if you write this, I'm sure any examiner will like it, because this is something that I expect from a postgraduate, not from an undergraduate maybe. So envelope of motion. Just to give you a clinical example, it's flowing in this pendulous motion. The tip is not cutting and the top is not cutting. What's working is in the center. So suppose this case was referred to me from somebody. It got blocked. Canal is not blocked by nature. Believe me, it's man-made. So the earlier dentists used larger files in a quicker motion maybe and plugged it, and the debris is blocked. Now we need to clear it. So what we do is we use a smaller files with some chemicals like EDTA and soften it and try and get to length. And then we remove. That's when this envelope of motion will help you. And we worked on that canal there, and then you went that way. So it's filled up now. See, the root canals are filled. The white things that you see are a complete root canal that has been filled. We kept some Teflon, put some glass ionomer, referred this case back to the doctor who wants to do the next job. Like you saw a glide path file, initially they were only hand files. You also have now something known as a rotary file. This is a rotary file. It's a glide path file. See, I'm going into the root canal and coming out. They're all worked on the microscope. with a lot of wet clinical condition. You see the chamber, it's flooded with a lot of chemical. It mostly is hypochlorite, sometimes a mix of hypochlorite and EDTA. Why? Because I want lubrication and I want many other advantages what EDTA provides us, right? So you're going in and out, never a dry canal. This is a rotary glide path file. So we leave glide path there. We finish pre-curve filing. I only want to speak about patency filing. You know what patency means? It's nothing but purposeful placement of an 8 or a 10 or a 15 number file little more than the tooth length. That is the apical diameter, minor diameter, not the major diameter. So we go there and you see at the end, that's the end, and you go little beyond. Basically, I'm trying to clear the debris. Most of the times we work a lot and it's done well, preparations are very good, but unfortunately it's not cleared well. So that's when you need something to clear. So try and clear it this way. So that's a more important thing. So this is apical clearing of the debris, where you're peeping in and peeping out, not too much out of the root, in the root between the major and the minor diameter, just to clear the debris. It's one of the important factors, because any preparation, let it be amalgam, let it be composite, let it be root canal, toileting of the cavity is the last principle. This, what I'm speaking, is called toileting of the cavity. So glide path is this way. You know what we did here? We actually took an extracted tooth, pushed the file to full length, which you'll not do in the normal tooth, held it there for a minute, and you turn the file and took it out. We think the root canal is curved, right? That is 2D. I just want you to understand how a 3D would look. The video that I'm turning will try and show you how a 3D was looking. It's not as simple as it looks. A 2D is just one curve. 3D goes even in the bucco-palatal, bucco-lingual direction. That's what you should try and visualize, because root canals will be much simpler then. We leave it at that for an undergraduate level. Again, if you put the file in the root canal, when you take it out, see, you can see which side it's turning. You only need to work on that side to prepare the root canal. You had words like step back, a step down, or a step back and a crown down. One was conventional preparation. We prepared to whatever sizes. There are other preparations of reciprocations and crown down, and ultrasonics. I'm not going there. What we'll speak about is step back and step down. Step back is what? I've gone to the root end, say size 25, but 20 millimeters length. My working length is 20 millimeters, and I've enlarged till 25. For some reason, there are multiple curvatures, and it is a tight binding canal. I'm getting stuck somewhere in between, and I'm not going to go there equally every time, systematically, serially. For which what we'll do is, we will start removing the restrictive dentin above the apical end. So this was a 20 millimeter length, 20 size, or 25, I said, enlargement size. So I will take a 30 size file, reduce 1 millimeter. So 30 size file at 19. Clean the cavity again, recapsulate, patency filing, everything. Take the next file at 35 at 18 millimeters. Again, clean it well with all those irrigants, hand files, smallest files, apical clearing files, patency files, recurve files, everything. So 20 becomes 19, 19 becomes 18 in length. But what happens? Diameter was 25, becomes 30, becomes 35. When you go to 40, you make 17 millimeters. When you make 45, you make 16 millimeters. You make 50, you make 15 millimeters. That way you're stepping back, which means you're trying to remove all the resistance that you got in the root canal because of any reason, to clear your pathway for a better cleaning, for a better obturation and a completion of a root canal. This was the earlier concept. We still follow it. Believe me, we follow it. About 10 or 20% of the times, you still need it. You have no choice. But today, what's very, very popular is what crown down technique is all about, which means you start from the top. You start with a larger file, a bigger file, a much bigger tapered file. And you know what? We are working on the sides and not the tip. The tip doesn't cut, only the sides cut. And then we'll use a next file to go deeper. Sides cut, a next file to cut, and next file to cut. So it keeps going that way. So what happens at the end of it is, you're only going to the root end with that one file or two files or three files maximum to prepare the root end. So that's a pure crown down technique. Just to revise all what I said, We divide the root into 3/3, the coronal third, the middle third, the apical third. I will use a larger tapered instrument. Just an example, okay? Say 8 taper or 10 taper or 12 taper. It doesn't go anywhere far. It is just on the top, but it opens. When it opens, I can see the next level. I'll take a smaller file than the before, say 6 to 8 tapered file. I'll open the middle. Then I'll use my hand files and go till the root length. I'll make my working length, and then I'll start working on the root end. There I'll use maybe 4 or 6% files. These are only tapers. Then I'll say I'll end at 25, I'll end at 30, I'll end at 40. That becomes the diameter. So length of the root canal is important. Taper is not so important. Diameter is also important. Okay, so understand this concept. This is about root canals. Now when you shape, you do this. So entry, what happens? Coronal flare. Why do you need to flare? You don't need to all the time. If you have a large canal like a front tooth, an anterior, like a canine or a central incisor maxillary, you don't have to. A distal root of a molar, you don't have to. A palatal root of a maxillary molar, you don't have to. Where you need to is all these obstructive, restrictive dentin. Like you see here, this is the point. There are many a times on a mesiobuccal root, it becomes more difficult. That's when you will try and do this. You will use that files to brush it out and remove the restrictive dentin. That's called a pre-flare technique or coronal flare technique. By removing that restrictive dentin, your root canal becomes that much more straighter. For which you have various rotary drills from different companies. Use whatever suits you, whenever suits you. But today you are writing a paper to understand that much. So you need to understand one more thing. How far to go? You have to go till the minor apical diameter. That's the constriction that we have talked about. Because endodontics ends there. Beyond that is a periodontium. It's all about your cementum. It's all about periodontal ligament and the rest. So a simple technique of working length is this way. This is, of course, we have done post shaping because I've taken a 35 size file. We also do 2 times, pre and post. So all what we're doing is we are trying to put a lip clip. There are 2 components in it to complete the circuit. I'm sure you know in working length, right? Then I'm putting a file clip. When you put a file clip, it starts going straight. The file goes in and the reading starts to come. There are a lot of requirements in it, like it has to be a dry tooth, but a moist canal. Leakage should not be there. Rubber dam is a must. And as you go deeper, you have to confirm it twice. So I've used the black color gloves just to show you. So I went beyond, it's 0, 0. You have to come to 0, 0. And then come back and reconfirm it once or twice. Adjust the stopper. That's my working length now, 0, 0. I reduce it, go up, and then maybe I come back again just to confirm it. So working length is all about this. There are many ways to do working length, from radiographic technique to mathematical formulas to combinations. This is electronic way. That reading that shows 0, 0, transfer it to a scale or an endo block, and you're getting 22 millimeters, 22 point something. That's your working length. Right? This you will translate it to every file that you work from here on that goes to the apex. That's how you do the shaping of the tooth. So just quickly, I'll play this one last video. This video is all about opening an access cavity, complete root canal it is. I'll maybe run it fast. Once you open the root canal, you start cleaning it a little in the chamber. And then you get the files to length, get the working length, if it's possible. And this is how you're using a rotary files. This is from some system of some company. You can follow anyone, but this is how you start enlarging it. So I'm just running it fast. So if you see here, start cleaning in between and running it fast. So if you see, this is one of the second or the third last files I'm enlarging, and then you'll clean it. We're working under the microscope for a front tooth through the crown. There's a case of pulpitis, which is referred, of course, and indicated case that way. And we start irrigating the canal. and then we use a couple of rotary system files, maybe 3 files, maybe 4 files. There's also single file systems. If it's a vital tooth, if the diameter is good that you achieved, it's acceptable. There's a technique to work on it. All I'm saying is just follow this, right? Okay, that's about shaping. Following which, you clean it well. And once the cleaning is over, we will dry the root canal with absorbent paper points. After the paper points are placed for about 20 seconds, and then you put the sealer, you put the Karapurchas, do a lateral compaction, and you'll seal it at the entry point. And I'll show you an X-ray and stop this. I've done a down pack and a backfill in this. I don't want to show that for you all now. I'll skip from here. So this is an obturation for us, okay? So I'll leave it at that. So if you want to just see the radiographic picture, when you make a root canal or write a paper, remember this much. There's a preoperative picture that you've taken. There's a working length, maybe you'll take, today we can use apex locators. The working length picture, a master cone picture, and then you have a post-op picture. So there are 4 pictures that you need to make in a root canal preparation. What I am focusing mainly is on biomechanical preparation of the cleaning and shaping. Okay, that was for one of those papers. I think we went a little long there. We'll just talk about another topic. We'll go a little fast here. Same way you construct another paper. If you have a question on bleaching of discolored teeth, in my mind, first, of course, maybe introduction, a definition, a classification, mechanism of bleaching, agents available for bleaching, procedures or protocols for bleaching, treatments of, say, tetracycline or any of the bleaching rather, and of course its conclusion. Definition, of course, cannot be changed. It should be word by word, and I expect you all to write the definition from that particular author. Everybody has a definition. Like in the earlier speakers when they spoke about different topics, right? Say suppose cavity preparation. G.V. Black has given a classification, Marzuk has given a classification, or somebody else has given another classification. Student has given another classification. So please follow the same, okay? So when you talk of tooth discoloration, now you know Nathu's classification is one. You have extrinsic or intrinsic. Like I said, these notes, please read from your books that your teachers have given you, or from the best places that you can achieve from. I am not here to give you notes that way. All I'm trying to tell you is, in today's day, I know it's not a nice time for any one of us. But don't worry, you know, in 1911 or 1919, I think there was a Spanish flu pandemic. From then also people have been graduating. So we all will graduate, you all will graduate, okay? So bleaching agents, you need to understand what are the different types. You should understand one thing. Anything that can liberate oxygen is a bleaching agent, because it's going to liberate oxygen radical, and that's going to bleach the tooth. So start thinking, what are the chemicals that can help you? After all the tests people have done, they've said, okay, hydrogen peroxide can work, sodium perborate can work, carbamide peroxide can work, and there are some over-the-counter products also. Even titanium dioxides and many new materials. I'm not going to go into that because that's about laser bleaching. Now here, what are the procedures? You can classify it in many ways. I leave it to you. You can say in-office bleaching and home bleaching. You can say vital bleaching and non-vital bleaching. You can mix both of them and say in another classification. Everything is accepted. But if there is a way to quote it, do that. That will attract you a little more of weightage on your paper. So intracanal bleaching, of course, you know how it is, why it is. Today, we don't want to sometimes do a crown on the front tooth or a veneer on the front tooth. But having said that, after doing a bleaching for a couple of weeks, now if I know that the tooth is not going to get back to the normal color because it's an old case, the discolored case, the dentin has got all absorbed, then we need to put a veneer. We may have to go for a crown sometimes. That's a different case. But what you need to understand is, first try and bleach the tooth. What happens is in bleaching, I said it's an oxygen release. It helps the tooth to change the color. But if it's the old case, the penetration of that discolored material, it might be a sealer, it might be bacteria, it might be byproducts, it might be debris, anything that matters. If it's gone to the dentin too deep, it becomes too dark. And you all know enamel is what? It's a transparent structure, a translucent structure. It only drinks the color of the tooth. That's it. So all I want you all to understand is enamel has nothing to do with bleaching. Though we use it on the enamel, what we need to understand is how deep that discoloration has gone. Having said that, that is one of the reasons why I put tetracycline as a different classification, because here most of the time bleaching don't work. In a hypoplasia, it may not work because there are bands, there are pits, there are many other defects. That's when you need to do an abrasion technique, maybe macro, maybe micro. Like sometimes you may have to cover the tooth like a veneer or a crown. You need to see the quality of the tooth structure. So this is very important. So when you get a question on bleaching, understand this much. Start from definition to conclusion. Like I said, you can put more headings. I'm okay with it. But see that you have a content on it, write about it. And to the question asked. If there is only write about bleaching agents, you'll only pick about those. Rest are not important. To the point. And you need to be elaborate. So I'm just going to show you a small video and a clinical case here of how we did bleaching. Bleaching, like I said, should be freshly prepared agent. You have a powder and a liquid, or you have an injectable system. Use a Opel or a Opel dam or a quick dam or a light dam or a gingival dam or a flow dam. So many names are used. Okay. In the gum, you see that green color layer. That's nothing but a light cured resin. It's a flowable resin. It is just instead of putting a full rubber dam, sometimes we may just do this on a white tooth. And then this is a light activated. It's actually laser. So you can light activate a agent. It's a walk-in, walk-out procedure. 1 or 2 sessions. It's a vital tooth bleaching, in office bleaching. You can't do it at home. You need a doctor, a dentist to do it for you, right? So this is how we do it. So see the before, see the after. So I'm just showing you a picture. See how the before and after is. You can many a times get good shade changes. It's of course a cosmetic procedure, but there are dentists, there are patients asking for it. So you start from here. These teeth are not bad looking at all. And see, we did a bleaching, again a blue colored gingival dam, a white colored chemical. Bleaching was done on upper teeth first, then the lower teeth, and then a lot of restrictions, precautions, post-op instructions, all that you read, please. And you see this before and after. It's come bright white, like a chiclet white color. You can't expect it to shade. I know in Prosto you've read about shade guides, like the Vita shade guide. You have A, B, C, D, A1, A2, A3, A3.5, maybe A4 sometimes. And similarly B1, B2, B3, B4, and C and D, and it goes. You can't expect a D shade to come to A. It did not happen. A3 may become A2, may become A1 sometimes. But don't expect multiple jumps from each of those gradients, okay? Just to know for you all. Okay, let's go to the next topic. We have some other topic or something called as post-endo restorations. In a post-endo restoration, if you ask me, first thing is like, you know what? I want to think about why do I need to do a post-endo restoration? Even before starting a root canal, okay? Not after. It's like this, you know. There's something called as a diagnosing a case. I know it's a root canal, but ask my question, next is what? Can I restore the tooth at least to function, if not for cosmetics or aesthetics? If I can do for both, nothing like it. So that's called case selection. So select the case only if it's indicated, please go in for it. So that's about consideration in treating endodontically treated tooth. And then we go in for protecting the remaining coronal tooth structures, restorative treatment planning of non-vital tooth, because it's non-vital root canal treatment has been done, evaluation of tooth or teeth, factors determining the post-selection, and clinical recommendations or considerations. This is what I thought I'll write for this paper. You can write another way also, but a flow chart, like I said, anything can be thought about. So assessment, I told you what it was between diagnosis and case selection. Case selection is important. If the case is not right, it goes out. You go for the next procedure, maybe an implant or a bridge, I don't know. Considerations in treating endodontically treated tooth. What are the considerations? Of course, anatomy. How deep is the curvature? How short is the curvature? How acute? Can I put a post? Can I put a knot? Biological. Does it have a good ratio, crown root ratio? Is there enough bone support? or mechanical? Will it help me or not? After doing, is there a thing, or is it going to crack or fracture, or it's not going to help me at all? Protecting the remaining tooth structure. This is a very important point. Most of us fight to get it all the time. It's nothing but a resistance form of a cavity. We have forms like outline form, retention form, resistance form, convenience form, and then it goes on. We forget actually. Last is toileting of the cavity, right? So the resistance form is this. Feruling is nothing but encompassing the tooth with the cover structure. It might be a tooth ferrule or a core ferrule or a crown ferrule, whatever it is, that you can decide on the tooth remaining. But you need to put something on top to cover it. That's how you help tooth and the processes together. Restorative treatment planning of non-vital tooth. Why I put core here is core is 100%. Every root canal you open, you need to close. And that's called the core built up. Post may not be every time. You don't need a post. If there are good tooth structure, the strongest portion of the teeth, I say, like what are they? Say oblique ridge, say marginal ridge, transverse ridge, cusp tips, or cingulum. If these are intact for any reason or all reasons, then don't need to put a post. Don't have to destroy the tooth. Just close it with a core built up. It's enough. So evaluate the tooth well. Once you evaluated it well, okay, core materials. There are so many core materials. You have a composite material, you have amalgams, which has been covered earlier lectures. I saw that. You have cast gold, you have onlays, you have endo crowns, you have inlay onlay type of materials, and you have a full crown. Anything is possible. Slowly, of course, we are doing less of full crowns, coming to endo crowns more. Okay. Evaluation of teeth. Anterior teeth have got different evaluation, posterior different. You know why? Structure and the make and the positions. Behind we use it for chewing. You need strong. If a person's masseter is developed well, you know his teeth are going to get flatter soon. He's going to lose his vertical height of the face. The canine guided occlusion. It's going to be a groove function. The incisal guidance. These things go away. So you need to understand these things. So of course, this will be a little bit of prosthodontics now. So evaluation of teeth is important before going to the next step. You also have something called as factors determining post selection. So what are they? Of course, very classical in every book it gives. I'm sorry. It goes like this. It says about factors determining is what? Post length, diameter, it can be width, that's called diameter, anatomy, configurations, design of the post, and also, of course, the luting cements and so on and so forth, right? So here I'm going to play a video just to show you different posts that we have used. Okay, you can see a steel post, a metal post, a fiber post, a cast post, a core built ups. Different things have been happening. We have done this. So I'm just showing you this much, just to show you a small glimpse of different procedures that have been done. All these we are doing. Believe me, endodontics is being so interesting. Dentistry is being so interesting in these days because we've got excellent material that we're using. These are fibers we've used on this patient. The fiber post built ups, one of my favorites, right? But never ever use something that's active in the canal, that is something that is threaded in the canal. I want something that's passive, parallel tapered maybe. So no screw post, please. Screw posts are disastrous. They're all gone. They come in gold and silver color and all. They're not nothing to do with the color because they're not gold. They're only colored. Okay, they rust. They corrode. Cast post, yes. A badly broken down tooth where you have no crown root ratio, where you have no enough height of the tooth for your axial wall, then maybe yes. So this is one example of cast post. GPs were removed up to the straight part of the canal, and then the posts were fabricated, tried in the model, and then put in the patient's mouth for a trial, and then cemented maybe. So this is how it comes. Okay, this is a case of cast post. Now I'm going to play you a video on a fiber post. Fiber post, just for you all to understand what it means. It reinforces the crown and the root ratio because we spoke about the length, the diameter, the taper, the fit, the cementation media, the surface texture, many reasons. They all are covered in theory. This is one system that we followed. Now there's a broken tooth here. And you see there's a lateral incisor that's broken. For this lateral incisor, we're trying to put a post. So we try to put a rubber dam first, which is very important. Isolate the tooth first, of course, especially in these times where you don't want to come in contact with saliva. Put a opal dam or a blue color dam or a white color dam for a sealing. Once it's sealed, then you've done a floss tie technique also here. You'll take a drill to remove the GP point to create the space. A micromotor drill and a post drill. Isometric post is what we've done in this case. Why I'm playing these videos or clinical picture is when you read your theory, if you can correlate this that you had seen it somewhere, I think it becomes that much more easy to reproduce. At least that's true for me, So that's why I said, okay, I asked Abrar when I spoke to him, to Dr. Abrar, you know what? I don't want to go a theoretical way to show. I have all the presentations in me here to show you a theory and bore you. And at the end of the day, when you heard for 4 hours, I don't think you'll be interested to see a lot of theory also. So that was the fiber you see. That's a newer post that we're using now. It's a glass fiber post. We took a post there. I'm not going to go into the theory. We have to have a bond. See, now to bring them together, you have to condition. One part is the tooth. One is the post, right? How do you condition the tooth? You etch the tooth, you wash the tooth, and you dry the tooth. On the other side, you have a fiber post or a metal post. You have to cement it, luting it. In resin chemistry, when it is resin, you need to bond the post also with the luting, with the cement, the resin bonding agent. Or sometimes you use a silent coupling agent. So that's what we're doing. Conditioning the tooth here. It's a total etch technique. A phosphoric acid. Wash the tooth nicely. Of course, I'm activating nicely with a probe there. Going to the full length, very deep. I'll wash it with the regular distilled water. You can use a 3-way, it splashes everywhere. So I prefer a syringe. Lots of water, copious amount of water. And once that is done, you dry the canal because you want to put a bonding agent now. A dentin bonding agent is chosen. If you saw there, I made a dentin bonding agent. That was, I converted a light cure into a dual cure there by using an activator. That's what a video showed you. But as students, you just write it as a dual cure dentin bonding agent that can go to the deepest layer and self cure also and so on. Once you apply the bonding agent, you throw air. It's called air thinning. Blow drying to move it everywhere and remove excess. Also use absorbent points to remove excess. Now the tooth is ready. The post was ready there previously because one of my associate doctors or assistants have cleaned it up and kept the post ready. At this time, I will take an injectable material, a light cure it, of course, first. That's because it will light cure the tooth, sometimes even the post material. This is a core flowable material that we're using, like a luting cement. It's a 2-in-1 and a core built up. With the thin tip, take it straight into the deepest portion of the root canal. This way, deposit it and then withdraw the syringe out so that you get no air bubbles as much. Take the post and do a pumping, like how you do cone pumping in Gadaparcha. That's how you do a pumping and let the excess cement escape out. And then you have to put a matrix band and build it up. This is a broken down tooth, so I use a different type of a core form to build it up. So you light cure it buccal and lingual also. More light cure is always better. So occlusal, buccal, lingual, you saw here. That's what you will do for all the other cavities, even in vital tooth, even if it's a simple restoration. Once the light curing is done, I fill that remaining material in a core form. I would say if the tooth is good, just use the band, matrix band, it's enough. This was broken down tooth. Take it into on the tooth under pressure. Press it tightly, remove the excess, and then you light cure it. Occlusally, buccally, and also palatally. Once that's complete, you can remove the cover out or cut it out because I didn't have a matrix band here. I use a core form. And then you do the tooth preparations. You remove the excess out there. And this is how you will build up a badly broken down tooth. You see the picture now, you have a tooth built up done. It's a crown prep done sort of for a ready crown that can be placed. So that's how you should do it, okay? Okay, we'll go to another question. 2 more to go, but now I won't show you the pictures or videos. I'll just speak a little about it. Endo-perio, endo-perio. If the question is endo-perio interrelationship or any other relationship on endo-perio, I would write on etiology, pathway first, etiology next, the difference between them, the etiopathogenesis, the classification, clinical features, treatment plan, and then conclude it. So when you ask me about pulpo-periodontal pathways, there are so many classifications given by many people, you know. If you say, you can talk about Franklin Wayne's classification, Glickman's classification, Stock and Gulabiwala's classification, or any other classification like Grossman's classification, whatever you want to. But for a simple understanding, I want to say this way, you know, as a student, you understand this much. You have a tooth and you have a periodontium. Periodontium consists of 2 hard and 2 soft structures. You have a bone, alveolar bone, you have a cementum, you have a PDL, and then what happens, they're connected to each other, right? When they're connected to each other, and gingiva, of course, when they're connected to each other, what happens is there is a communication in many ways with blood supply and nerve supply. For a blood and nerve to go, there may be portals of exit, which might be in the form of a main canal, additional canal, accessory canal, lateral canal, developmental defects, incomplete reunion, whatever they may be. So understand this much. So if you have to simply know how all can it connect, a tooth may be simply involved because of a decay or a caries or a fracture, occlusion load, whatever it is, you may call it as primary endo lesion. A tooth is involved and only endo is involved. It might be a pulpitis to apical periodontitis, but it's primarily endo. Now the patient can go through it, the pain and the swelling or whatever it is, and still not come to you. It will spread in the bone. Then it becomes what? Primary endo, because it started from endo, it went to perio now, because it involved all the other structures around it, the supporting structures like the foundation. The first classification was primary endo, now it became primary endo but secondary perio, second classification. Sometimes there are no problems, patients are not well to do, or they're not well to do, they don't maintain well, and they have pockets and whatnot. And in that pocket, it might be just a perio problem. Just treat that much. That's the third classification according to a clinical classification, primary perio. But if the patient has not taken care of it well, not come to the doctor on time, the perio pocket has gone so deep from the furcation till the root and become a communication. It becomes primary perio and secondary endo. That's the fourth classification. Sometimes you may have a patient where there is endo involvement and perio involvement and combined involvement, both involvement. What came first, even we don't know, because patient comes so late. So that's a different thing. So that's all about it. So primary endo, primary perio, primary endo, secondary perio, primary perio, secondary endo, and last is true combined. So that's a classification you need to know. So pathways of communication starts from them, from pulpal to periodontal. And you also have the differences here. You need to understand, to know the differences, you need to understand these points. I'm sure you can read your books, the notes that you have with you. What's the etiology? Why the pain is calm? Is the pain sharp? Then it's endo. If it's dull, it's perio. If there's a swelling, is it apical or is it near the starting point of the gingiva? Percussion, when you percuss on top, it is morely endo. When you percuss on the side, it's morely perio. But don't percuss with a probe or an instrument, please. Finger is enough. The patient is already symptomatic. When you press, they will say yes, okay. Probing, pocket depth, all that can be probed. Sinus tracing, when you put a GP point in the buccal sinus or lingual sinus or the palatal sinus, you just cone pump it slightly and take it to the full length. The GP point will go and curl around the cause. Otherwise, the sinus doesn't come. That sinus tracing will tell you, is it endo or perio? Because it might be too apically or too coronally. You decide that. Mobility. It might be a class 1 or a type 1 to type 2 to type 3. It might be endomobility, which goes away actually in pulpitis cases, in abscess cases, not mainly pulpitis abscess, alveolar abscess, acute. It comes up, or it might be another cause altogether. But if it is a perio cause which has a mobility, the prognosis is guarded. Then you have the etiopathogenesis. Again, anatomic considerations, etiological considerations, contributing factors. Like I said, classifications, Simons, Olitz, and Pollocks. You take what you want, it's okay. One of the last topics I'll discuss now in 2 minutes is traumatic injuries. One of my favorite topic, interesting topic, and the most needed, because this is very sad when it happens. Because unfortunately, most of the patients cannot reach the dental office on time. And we end up losing the tooth in a matter of time, sooner or later. So if somebody can go deep into that, I know pedo, I know there are traumatic involved agencies and organizations, but this is a very sad thing. Anyway, when you get a question like this, what's the cause, what's the incidence, what's the classification, the terminologies, the management of traumatic injuries, involving pulp, not involving pulp. If it is not involving pulp, it becomes conservative, like before class 3s or type 3s. If it is involving, it becomes to endodontics. The entire classification of LEs will go that side. So you follow one classification. You can follow any, whatever you deem fit. Last is conclusion. Okay, that's how you do it. So these are the few topics that I thought I'll discuss. So terminologies, what do you want to write? You will write about all these terminologies. What are caries lines, cuspal fractures, cracked tooth, split tooth, vertical fractures, or when you talk of classifications, they can be anything like this, Ellis-Davy or Anderson's. Anderson is a big name, of course. You can see whatever it is. Conservative management. Is it just, I said conservative management, so it's before third classification. So it's only in the enamel, or enamel and dentin only, not involving pulp. So you can restore them many times. May put semi-permanent restorations with the liner, with the pulp capping, and then go for permanent. Both are okay. So that's how we go it. Look at the features. Always when you want to decide and define your diagnosis, you need to have a clinical picture, a radiographic picture with the patient history, bring them together, then come to a conclusion for a treatment plan. But the most important thing in any treatment you have to write in a paper is follow up. If you write follow up for every procedure, it's okay. There's nothing wrong. That's more important. We don't follow up sometimes. Okay, that's important. So as I conclude, what I want to tell you all as young, budding, soon to be graduates, when you read and read. You read why, to remember. To remember, when I told you something, you need to know how you can repeat it. When you read something, can you repeat it? When you read something, can you repeat it and recollect it? When I read something, now just we saw traumatic injuries. If somebody is very smart with their cognitive skills are great, they would have had the picture in their mind already. I had some classmates with me who were very, very smart. One scene, it's a photo capture. I can't get that. I need to read. I need to read again. Once I read, I may have to repeat what I've read. And what I've repeated, can I recollect in my mind? And if I can do that, read, repeat, recollect, and then reproduce in the form of speaking it out or writing it out. If you can come to this level, right, I think things will become very, very easy. I think with this, I'd like to thank the team of MUHS who have invited me to speak on few topics to help you navigate yourself for a better understanding on your paper. This is how I sign off thermoplastically. It's a thermoplastic Ganaparcha, okay? So signing off, thank you. Thank you so much, Kishore. I know you're coordinating the meeting now.
Yes, sir. Yes, sir. Thank you
everyone for inviting me here.
Yes, sir. Really thankful, and it was really good for the student to have a clinical insight. One part is theoretically covered, and you have covered some clinical hints. You have given some clinical hints to the students once they graduate, after they are going to in the practice. So this is definitely going to help them. I also start the Abrar sir. I also thanks MUHS coordinator Mr. Kedare, Dr. Shehnaz, Dr. Ashna, who have been patient enough to be all parts. And thank you all the speakers, Dr. Manjusha Warhadpande, Dr. Shishir Singh, Dr. Vibha Hegde ma'am, and of course, Dr. Vivek Hegde sir. So thank you, sir. Thank you everybody for all your cooperation. Sir, sign करूया केदारे सर.
हो झालंय सर. थँक्यू सो मच.
ओके सर. थँक्यू सर. तुमचं पण थँक्यू. खूप धन्यवाद. ओके चलो बाय.